Good morning and welcome to day 2 of the Board of Registered Nursing Board meeting. We will take roll call to establish a quorum at this time. My name is Dolores Trujillo. I have been appointed by Governor Newsom to serve in the direct care provider role, and I am the current president of the board. Vice President Neelu Patel.
Good morning. My name is Neelu Patel. I am the Vice President and appointed by Governor Newsom for the advanced practice role.
Thank you, Neelu. Board Member Allison Cormack.
Good morning. My name is Allison Cormack. I'm a public member of the board and I was appointed by the Speaker of the Assembly.
Thank you, Allison. Board Member Jovita Dominguez.
Good morning, Jovita Dominguez, appointed by Governor Newsom in the Education and Licensing.
Thank you. Board Member David Lawler.
Good morning, David Lawler, appointed by Governor Newsom in a public member role.
Thank you, David. Board Member Patricia Nguyen.
Hi, everybody. Tricia Nguyen. I'm a public member appointed by Governor Newsom.
And Board Member Vicky Granowitz.
Vicky Granowitz, appointed by then pro tempore Tony Atkins as a public member.
Thank you, Vicky. And our board staff, our executive officer, Loretta Melby.
Hello, my name is Loretta Melby, or Lori, and I'm the board's executive officer appointed by the board.
Thank you. And our board counsel, Harry Scoletzi.
Good morning, Harry Skoletsky. Actually substituting for Reza, who is on extended leave.
Oh, no,
Right on?
maybe it worked. Yeah, did it work?
Okay.
Okay.
Thank you. Quorum has been established. And we will move on in our agenda. Item 2.0, these are the general instructions for a format of a teleconference call. BRN moderator.
Good morning. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature. When the board reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment" in the question box, which is typically in the lower right of your screen. We will also query DCHQ for a physical presence if anybody physically wants to make a comment. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes in, you will be prompted to unmute. If your question can be answered, the board will respond accordingly. When making your comments, speak about anything you believe is important for the members to know. Remember, board members cannot address any item not on the agenda. Items not on the agenda at the moment, items that you would like to add to a future meeting, or items that will be discussed later on the agenda will be discussed at their correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when board members or BRN staff are not speaking, I would like to remind them to mute their microphones. If I detect background noise during the meeting as a result of unmuted microphones, I will mute their microphones automatically.
Thank you, board moderator. So just some housekeeping here at the beginning of the meeting. You'll see on the agenda that there is a call out for the board to finish any unfinished items from the day before. There was one item that was not completed in in closed session, sorry. And so the board will be recessing to closed session after we complete this announcement here. So the plan for today is to go into closed session, wrap up the one item. We have every intention to be back in open session no later than 11 a.m. That allows our board 2 hours to complete closed session and take a break. And so then the plan is to no later than 11 a.m. enter back into open session to address agenda item 4.0, which is the final section of our board meeting for today. And then at the close of 4.0, which will include 4.1, 4.2, and 4.3, we will have public comment for items that are not on the agenda, and at that point adjourn for today. So thank you, guys. We're really sorry that we weren't able to complete everything in closed session yesterday. So we will complete the one remaining item in closed session and then open into open session to go into 4.0. Thank you guys for your patience, and we'll see you soon. Thank you and welcome back. I'm going to have the board president open up and establish a quorum. Thank you guys for your patience.
This meeting is being recorded.
And we are back for day 2 of the Board of Registered Nursing Board meeting. We will take roll call to establish a quorum. Dolores Trujillo present. Allison Cormack,
Cormac, present.
Board Member Jovita Dominguez,
Dominguez present.
Board Member David Lawler,
David Lawler, present.
Board Member Patricia Nguyen,
Tricia Wynn, present.
Board Member Neela Patel,
Patel, present.
and Board Member Vicky Granowitz.
Granowitz present.
Thank you. We will now move on to item 4.0. This is the report of the Enforcement Investigation Intervention Committee. Patricia Nguyen.
Thank you very much, President Trujillo. So as you know, we've been working on this item for many months. We've had several hearings, lots of public comment, and we did direct our executive officer to review individual program participant requirements. So I'm going to turn this over to Executive Officer Melby at this point to inform the board members and the public as to what she has found.
Thank you for that. So I do want to preface this that we're just beginning this process into the deep dive. I've been able to look at it from a systemic kind of point of view, look at it like how our board is set up, how our intervention evaluation committee is set up, how we utilize uniform standards, how we utilize our vendor Maximus, how nursing support group facilitators play into that, our program manager, Maximus's program director, and really just kind of go through that process. I have reviewed a few of the individual participants, but there are many more individual participants that need to review. And I'll explain why I didn't deep dive into them so much, because I truly believe that that deep dive does need to go back to the committee level. But I will talk through this process. I'm going to pause several times. I have copious amounts of notes in front of me, and I want each one of the members to be able to ask questions. And I want to make sure that I'm able to answer it to the fullest ability. I know that this part of our board meeting has been long awaited. I know right now we have about 117 participants on our call that are viewing us through WebEx. I know that that's important. And I know that this is recorded for perpetuity, so it will be referred back to many, many times, I guarantee you. So I want to make sure that each one of these are discussed and that you guys have the answers that you need. So the first one is just kind of to set the standard here. We do have law, and that is what is in our agenda item summary. So if you guys have the ability to pull that up, I recommend you pulling that up. The only thing that is on our agenda item summary that is part of our materials are the laws that require this program and support this program. And that's the laws that we are held to. As I'm sure you guys were aware, what happened yesterday, we had a public comment during an agenda item that we couldn't hear. It's not that our board members or myself didn't want to hear from that member. We are forbidden by law to take public comments that are not related to the agenda item that is in front of us. And so I know that seems like it's taken a long time to get here. But I want everybody to know that we have heard you. We are working diligently to get this matter fixed or solved, or at least process towards fixing it and solving it. I don't think that we have a silver bullet. I don't think that we'll be able to solve all the issues today. But I do believe that we can make an impact. And so when you look at the beginning of this, it talks about how in 1984, state law established that what was called the diversion program. In 2003 is when Maximus contracted with us as our vendor. And so that kind of shows you how long this process has been in place, how we've had success stories, over 2,000 successful participants, and that this is a program that I believe is something that deserves the attention and also really is a good program. I think there have been some changes that occurred that maybe aren't fully understood. And in part of like the change process, when you do the plan, do, check, act, you plan, you make the best intentions, you make the moves based on those intentions to be the best, to really look at it aligning regulations and statute, to really look at the public protection aspect. And then once you've planned and you've done, you do need to check. And that's where we're at right now. We're checking everything. Did this work? Is this working? Do we need to alter our path a little bit? And then we act again. And that's where our board is going to act today to make any decisions that need to be done by our board. So uniform standards came into place in 2011. And meeting with several people, that is when it was shared that we had a decline in participants. We used to have over 900 people in the Maximus participant program. Uniform standards came into place, and it was difficult to align to the uniform standards. It was a change in process, as we see what happened right here. Is there was a change in process. And the people that aligned with the prior process did not want to make the change to the new process. And so sometimes those people chose to leave or to not participate because it didn't fit with them. The one thing that I want everybody to be very aware of is with mental health and substance use disorder, if you're in a program that doesn't fit with you, you're not going to be successful. So it's not like we want to go out there and say you must participate in the BRN intervention program, because that could lead to failure. It's not guaranteed that it will lead to success. And so when you're looking for a program that will help you to be sober, you to have some help with your mental health, we might not be the one. However, we would love to be the one, but we might not be the one. The other thing to take into consideration is with our intervention program, it is an alternative to discipline program. And I think that's a key understanding that we have to put out there, is most of the participants chose to come into this program because they did not want to go into probation. They had caused some harm. They had violated the Nurse Practice Act. Something had occurred. And when they were talking to enforcement staff, when they were going through the process, they were given the choice. You can go into probation or you can go into intervention. And the participants made the choice to go into intervention because they want to be rehabilitated, they want to get the help that they need, and they want that confidentiality. If and when they successfully complete the 3 to 5 year program, it's confidential. All records are shredded. Everything is gone. It is not on their license. Nobody in the public, nobody out there has any record that they ever participated in this. And in fact, the incident that brought them in is usually erased at that point too. So there's no discipline associated with your license. So that precipitating factor occurred, but there's no record of it. And that's a big thing to really kind of take into consideration too, which is one of the many motivating factors to choose the intervention program. And so I wanted to make sure that that is put out there, that it's not something that we force them into, but they are given the option. And a lot of times people choose the option to go in there. Now, I'm just going to kind of go through many, many, many pages of notes here, so please bear with me. And if any of these are items that you want to further discuss, please get my attention and I'll provide as much information as I can on this. One of the items that were brought up in public comment and with various stakeholders of meeting was the clinical assessments. Those clinical assessments are done at intake, and part of that clinical assessment determines whether or not that person is safe to practice. there are many things that can happen with that clinical assessment. They can look at that and they can mark immediately that they are safe to practice, that there is not a risk at this point, and they could choose that the participant entering is safe to practice. We do have a requirement that they inactivate their license for the intake process, but they can go back in as soon as the IEC looks at the clinical assessment, assesses risk, and makes a plan. Now, they do go back to work as a part-time employee. They don't typically go back in as a full-time employee. Now, the one thing to take into consideration here is we heard several times saying I was forced to be off work for 3 months. I was forced to be off work for 6 months. The off work time frame is something that is evaluated by their progress in the program. How quickly can we get them into their first IEC? How quickly can we get that clinical assessment completed? How quickly can they have negative substance use screens done? And then the IEC determines that they can go back to work. There is not a set time frame that they are mandated to be off. There is not a set time frame that says you must wait to be seen. So one of the things that was noticed is there were participants that had not been seen, at their first committee for greater than 3 months. So that is a scheduling issue. That is not a targeted issue. It is a scheduling issue. So it wasn't like somebody said, I don't want this person to be in front of a committee for 3 months. So working with that, we have to look at what are some of the issues that led us there. Right now, we had to do a alignment to get all of our IEC committees in alignment with the law that we use for open meetings, and that's Bagley-Keene. Our committees were not necessarily following that to a T as we are expected to. And so you have members that are appointed to a committee that establish quorum. What you guys are familiar with seeing is you have a ELC committee. Dolores is part of the ELC committee. If she doesn't show up, I can't say, David, I want you to sit in on ELC and take Dolores's place and then make a quorum. And so what had been done previously is other IEC members had gone into IECs and filled that vacant spot to establish a quorum. That's not something that is supported. So we had to make those changes. While making those changes, it did delay some time in between, and that was obviously an unintended consequence. It's not something that we want to see. So just these last 2 months, they lengthened IECs and they scheduled IECs. There was almost an IEC every day in the month of July and going into August. And so that was necessary. It was a difficult undertaking, but absolutely something necessary. So going forward, I don't think that that's going to be an issue that continues. I think that was an issue that did happen, but I think that that will be cleared up. However, if that issue is ever identified again, we will just increase the length of our IECs and we will schedule in new ones. And so that there is something that we can do immediately on the board level. And we now have a better understanding of how that happened. And we can work with Maximus, who is our vendor at this point, to get people scheduled into those meetings. Now, to kind of go back to that clinical assessment part, if we have a documentation from a provider that has been approved by our board that meets all the requirements that stand up in a court of law that says you are not safe to practice, our IEC members, when they evaluate their return to practice, should take that piece of paper into consideration. That came from a licensed practitioner that has either some type of a medical license with a background in mental health and substance use. And if on their evaluation, they say they're not safe to practice, we need to get that reevaluated. That is not the only thing that's taken into consideration when we're looking at safe to practice. That is one thing that is used in an assessment evaluative process that we work for. But if there is a provider that does this for a living that says they're not safe to practice, we need to listen to that. What occurred was not necessarily that the person was not safe to practice. What occurred was that was a checkbox that wasn't checked. So on noticing that that second evaluation to clear that had not occurred, we had to clean that up. And so we had to get all of those participants that still held that piece of paper by a provider in front of them that said they were not safe to practice, switched over to a piece of paper by a provider that said, yes, they are safe to practice. And that needed to occur so that'd be part of that evaluation period. That is something now, again, is on our radar that will not occur in the future. We will be pulling reports, we will be evaluating them, we will ensure that those come down. The other thing is when we return them to work, so now I kind of tied that into the beginning where you could go back to work early on with a safe to practice order, not order, but eval. You can get another eval relatively soon after receiving the first one. There is not a set time frame that says do this and then wait 6 months, wait 2 years to do this again. So we could get those over whatever hurdle was evaluated by that provider that said this is the piece that's causing them to be unsafe. When that hurdle is addressed, they can go back in front of that provider, get a safe to practice. That goes back in front of IEC and can be evaluated, and that person can go back. There is ample evidence out there that success greatly determines a person's return to work. So if you're able to get back to work, back to some sort of normalcy, making some kind of income that really helps with the psychological aspect of being in the program. And in fact, with that not occurring, there is evidence out there that it could lead to increased suicidal ideations and potential suicidal attempts or successes. And that's, as a public safety board, that's something we always want to take into consideration, is we're not here just to protect the public, which is absent of our licensees. We are here to protect the public that include our licensees. And that is absolutely one thing that we want to always keep in our mind when we're looking at all these things. So any questions on that particular part before I move into some of the next sections?
You can go back to work full-time?
Not full-time, no. Our uniform standards have specific requirements to meet a full-time. And the full-time requirements requires 2 worksite reports that say that they've had good progress. And so you can't do that at a full-time employee if you haven't had the worksite reports first. So you have to be returned to work as part-time first. Get those 2 worksite reports that says, yes, you're doing well, then you can move into full-time. Now, if you're looking at this as a fast track, which that doesn't always happen, that could be a couple months. It doesn't have to be 6 months, it can be a couple months, because sometimes you can do a worksite report on a monthly basis, depending again on what the IEC orders or request. I have to say request because they don't order. So the IEC can say, I want 2 worksite reports a month apart. Then we have that. We can get them back in front of IEC and they can get a clear to go to full time. But there are other options that have to be clearly met on that uniform standard, which is in law. So these are best case scenario. You get in front of an IEC within a month, you get negative drug screens, you get into part-time work, and you do that, you could potentially be back in a full-time position within 6 months of starting the program. That is not typical, but it is, the ability is there. It is not barred from occurring. So that was one of the things I really wanted to put out there, because a lot of people are saying, as I was made to be off work for this long. There are circumstances that may dictate that. That is not a made to by the participant or a made to by the board or a made to by the IEC. It's an evaluative process that says these need to be met. And as soon as all of those are met, we can then make this decision. Okay. So another thing when we're looking at work is it has not occurred prior to this where they took into consideration the RN's previous work by looking at resumes and CVs. And so the ask that we will be bringing forward to the vendor, because the vendor does the employment approvals, will be that they seek out a resume or CV of each one of their participants. Any RN understands that we are not generalists, that we are educated as a generalist, but that we truly work as specialists. And in fact, training programs go on to talk about new grad programs. They talk about new to specialty programs, because you are not just hired in to be a pediatric nurse after you've been a psych nurse for 10 years. If in order to be hired in and trained as a pediatric nurse, they would put you in a new to specialty program, which is very similar to your new graduate programs. And so those are kind of the things that when you're looking at a employment approval process, you need to make sure that the orientation is there, that the support is there. Our nurses that are participating in this program are obviously having some issues with anxiety, with mental health, even if it is a substance use disorder, because we know that substance use disorder is usually something that is used for increased anxiety and stuff that is not being managed appropriately. And so you don't want to drop them into a work setting and they're not supported. So you want to ensure that there is ample orientation and that they have support, that they have a worksite monitor that checks in with them. That worksite monitor, there is specific training that Maximus provides through this. And there are specific requirements that must be met with that as well. And some people view that person as somebody that is a gatekeeper or punitive, and that's not an accurate description. They do some evaluations, and they do serve as a liaison essentially between the participant and Maximus in order to share information. But they're also a confidant. They are the one person in that workplace that knows that that person is in this program, because the rest of it is confidential. And so if that person is struggling, they can go to that worksite monitor, they can have a conversation with that worksite monitor, and that worksite monitor is somebody that they can get support from as well. And success of any addiction treatment, any mental health treatment, really comes down to the support aspect. And so that is a positive role, and something that I think does not need to be taken lightly and needs to be evaluated and used. Now, with that, there have been some comments that says, I can't work night shift. I can't work home health. I can't do registry or floating, and I can't have supervisory positions. Some of those are true, right? We know that in a registry or floating position, it would be difficult to have a worksite monitor because you're not in one location with them to be able to find you and check in. So that makes it difficult to utilize that asset, that resource. It's not that we don't believe that the participant can't do those positions. It's that it's not able to be orchestrated to be in a supportive manner and to allow for those reportings to come back. So it's not 100% no, it's that we can't accommodate that. The supervisory position, that comes down to the stress level that comes with that. You're struggling with mental illness, you're struggling with addiction. To add another layer of the supervisory aspect on that, when you're trying to kind of just take care of yourselves, that's something that has been seen across the board as something that's not super effective. If you're not able to be in control of you, it's difficult for you to be a resource to others in the early stages, right? That is something that can be looked at later on, because as part of the addictive treatment, it is to start to give back, to serve as a mentor and a resource later on. So can they do supervisory positions when they complete the program? Absolutely. That is not something that we're saying that they're not capable of doing. It's just they need to take a step back and focus on themselves. They need to be able to manage that aspect. Night shift is not a no. Night shift has always been looked at IEC members as maybe it doesn't have the greatest support. Maybe it throws off their sleep-wake cycle. You know, a lot of things that can be considered, need to be considered. However, we also have to look at that from a employment aspect as well. And we don't want to be a barrier to employment. So yes, participants can work in a night shift position. Sometimes that's a position that you've held forever. You know, you've always been a knock shift nurse. You've never been a day shift nurse. You rely on that. Your kids rely on that. Your home life relies on that. You can get approved for a night shift position. And the ask that we're going to work with on that is to kind of monitor those requests, either through us or our vendor, to find out how many are applying and wanting night shift and how many are actually getting approved for night shift. And if they're not being approved for night shift, why not? Especially when you're asking them if they're asking to go back into direct patient care and you haven't been in there. We all know that with unions and stuff at various employers, you don't get hired into day shift. That's not a possibility because you're a new employee. You will get hired into night shift. And so in order to make that accessible to be able to get jobs, that is something that we need to look at and make sure that that is very clear, that that is a possibility. It will need to be evaluated, but it is a possibility. One of the other requirements that I came across in public comment was that AA was required and that it had to be religious affiliation. That is not accurate. It is obviously an option, but there are many other community-based groups out there that do have an option for no religious affiliation, and those are accepted. Those are not turned down if they're showing that they're supportive, that they can use them, that they're accessible. One of the other requirements that we did here, though, is that some IEC committees are requiring a person to do in-person attendance. This had not been an issue prior to COVID, because prior to COVID, all support groups were essentially in person and everybody did all in-person requirements. They did in-person nursing support groups, all that kind of stuff. There is no evidence that says they must do in person instead of online. And so we will be working with our IEC committees to have conversations with them, to look at training, to see whether or not that is something that they want to continue asking for. Some of their ask is because we've been told that they believe it's more effective to be in person. The evidence doesn't support that yet. You know, if the evidence changes and it says that you must be in person to have that benefit, we can look at that at that point. But as we've seen over the last few years since COVID, is that even telehealth mental health visits are continuing because it has been very effective. And so these support group meetings can still continue to be online. They do not have a requirement to be in person. And we will look to work with IECs to say, consider why you're asking that. Now, again, IECs can recommend that they be in person. IECs can recommend that they can't work nights. Those are all recommendations. And as long as they can look at that on an individual basis, they can document why they're making that decision, and it doesn't look arbitrary or like it's a bit broad brushstroke. Those are still options, and we won't know that unless we do an individual assessment. So I just want to make sure everybody knows that I'm doing general statements here and that this is not participant specific. One of the other things that was brought about with IECs and the in-person requirement was taking into consideration the schedule of the person. So the participant, if they're working part-time, say 2 days a week, has a requirement to do AA meetings or whatever 5 days a week on top of their 2 days a week. And then they have a nurse support group meeting on top of their working 2 days a week. And then they have to do a check-in every single day as well, right? So there are a lot that our participants are managing. And so the ask is is that when the IEC members are considering that they do this, that they may want to take a look at the person's schedule. What are their other commitments? Because again, that's not something that we want to enforce if it's not able for them to fall in and be successful. One of the, excuse me, one of the other asks was, how can we work in remote testing, especially as we were looking through some of the requirements for these group meetings and these testings and working, and how can we facilitate that? So the the remote testing is something that is used in Montana across the board, but it's not solely just one test. And so as we kind of talked about yesterday, when we got that report out, when we look at our uniform standards, it talks about random testing and random tests, right? So we will not go to a complete saliva-based testing process for every single person. They can do that. We'll look at them case by case with Maximus or a future vendor. We did talk about that the contract does end with Maximus in December. They may choose to re-up, they may choose not to re-up, and we might get a different vendor. So when I'm saying them or a future vendor, I'm not trying to predict what's happening in the future. It's just letting you know that there's always possibilities with that. So with the saliva testing, there is a caveat to that in that they are required to do a DNA test first before using the saliva. And that is sometimes a option that a person will not want to take because they don't want to do a DNA test. That DNA test is used so that they can ensure that that saliva belongs to them. So that is an option that is out there, but it would not be the sole option. They would have to do an in-person testing various times as randomized, but the saliva testing is available. The other question was, and I believe we answered this at the last board meeting, a missed check-in. And they were saying a missed check-in meant that they were 30 days off work because it was considered a major violation. That has been corrected. A missed check-in is not a major violation and is not 30 days off work. We have had conversations with Maximus to ensure that, excuse me, to ensure that that does not continue. We are doing some checks to make sure that does stop. We have heard that recently that did occur again, and that it was a missed check-in and they were made to take 30 days off. We did have a conversation with them. They did correct that. Again, that is not something that is seen as punitive. That's not something that they said, oh, we're still trying to do these things. It's a training issue. You know, there are multiple different layers involved, and you can get these trainings out and then someone can forget, or maybe they were out sick on that day and so that training wasn't done. So we just need to follow up. That's part of the change process anyways. You don't just make change and expect it to happen. You always have to follow up. So it's one of these things here when I go through. Now, yesterday, we also talked about drug testing. And so I want to let you guys know where we are at with drug testing here. It is set out in our uniform standards. And in our uniform standards, they have a set amount for the first year and a set amount for the second year. On reviewing this, it was noticed that potentially the IEC members were not aware that they had the ability to change those. And so they were just leaving them at the set time frame. And so year one, I'm just trying to find it here for you guys. Year one is set up at a minimum of 52 tests a year. So we cannot do less than 52 tests the first year. That is set in law. But we can do as much as 104 tests in 1 year. Year two, the minimum is 36 tests for a year. The maximum stays at 104. Our understanding is that IEC was not aware that they could alter this, that they could bring it down year two and they could hit the minimum of 36. We have done some education. We will continue to do education to lower that down. Additionally, when we're looking at the 52 a year, that does obviously average out to 1 a week, right? And that the next one, when we dropped to 36, it's about half that. It was noticed that those were not dropped down. And so when they're talking about the financial implication, a lot of the financial implication comes from these testing. And so I think when we can get that aligned out and we can work with IEC to address that, I think that that will show that there will be a decrease in cost to the participants. And that also will decrease some of the stress if they're doing 1 a week, 2 a week or such, and trying to manage their 2 days of work as a part-time and manage all the support groups meeting and make it to their testing, especially if it's not in that region. You know, that's something that we can really look at that. And I think that IECs, now that they have an understanding that they can change that test frequency to the lowest possible, and at any point increase it back up and bring it back down. You know, it's not set at 36 and forget it for the next year or two. It's set at 36. And if we notice that other areas are starting to kind of set off some, like, hey, we need to look at this a little closer, they could bump it back up for a temporary time period and they could lower it back down. So it is random testing, it is randomized test, and it's something that IEC can address. There was also conversation on mental health intake assessment versus a comprehensive evaluation and who and how that should occur. Each one of the case managers at Maximus now are all RNs. RNs are able to do an intake assessment for mental health. That is something they're trained in. They do, many nurses have that training. They have specialized training, I think it's called ASAM, where they learn how to do that. That is different than the comprehensive eval. A comprehensive evaluation is done by a provider. The assessment, which is a nursing competency, that's the only ones that can do it, is RNs can do assessments, can do an assessment. That assessment is essentially to find out if you're a risk to self, harm to self, risk to others. It's like your standard kind of 5150 assessment. And then determine whether or not, if you are at immediate risk, what are your options so that we can help you get to your first IEC meeting. And some of those options may be to say, you know, have you considered inpatient? Have you considered a rehab? Have you considered some of these things? Now, an assessment does not dictate you have to. An assessment says, I think this might be good. However, that changes when it is seen as a harm to self, harm to others, or gravely disabled. That is a 5150. That would then be evaluated up, and there would have to be some immediate action done on that. So just to clarify that there. Now, the comprehensive evaluation is part of that provider evaluation. One of the other conversations we had around that was whether or not an IP, the intervention participant, can utilize their own provider. Yes, they absolutely can. That provider does need to be evaluated by the board to make sure that it meets the standards that are set forth in law. If they meet those standards, they can absolutely use them. The caveat to that is an IEC committee can review that and say that doesn't jive. I want a second opinion. And that IEC committee can say, I would like you to go get evaluated by another person so that I have a second opinion so I could vet that. But it does not mean that they cannot use their provider that they're established with, that they're comfortable with. There is no financial or personal relationship there. That is a provider-patient relationship. And that is supported, and they can do that as long as they meet criteria. So at that point, I'm going to pause again and make sure that we've covered that aspect of the evaluation. Did you have? Nope. Okay. Yes.
It's impressive. I was just saying that you're dissecting all this information for us, and I appreciate that. Thank you so much. I know it's required a lot of effort on your part. Clarification with, you've mentioned providers, so I'm assuming, but I want to clarify whether or not that includes an NP that can do an evaluation. So it's not
NP,
just the
yeah.
physician. Perfect.
Yes.
And the other thing is, does the assessment have to occur before the evaluation? So the assessment by an RN occurs before the evaluation, and then is it looked at and then incorporated in the evaluation?
Typically, the assessment would occur first because it's done on intake to the program. So could there have been a comprehensive eval done by a provider prior to enrolling in the program? Yes. Could we utilize aspects of that? Yes. But they would still need to follow the process. So they would have to go to a actual assessment that is determined as part of the program. They could pull pieces of that last one forward, but it does need to be a clean assessment. But again, it could be that they go back to their provider and do that. When you're looking at the comprehensive eval, it's a comprehensive eval specific for this treatment and program. And so you want to be able to check all the boxes, right? Answer everything that's done, because what you may have seen your provider for, a month ago may not be where you're at today when you're at your rock bottom, where you are coming into the program and seeking help. It can be a completely different kind of process. I'm going to end this because it is, people are looking, we haven't had a break here yet. So we will break at noon. That is in 3 minutes. We will come back and kind of go through more of this. But really, the goal is to train IECs, to train our board staff, to work with our vendor to come into alignment. I think a lot of these things that we heard from public comment were necessary. There is more to come, so I apologize. I do have to manage the person as well to make sure that we stay healthy and we're able to take it in. I don't want things missed. I know it's been a long couple days, so I want to make sure that that's there. And one of the things that I want everybody to know where I'm looking at this from is from a just culture standpoint. I have a history in just culture. I was trained in my management roles in just culture, and it is not ever part of just culture where you say it is your fault. It is, how did this occur? What can we do as a system to support that this doesn't occur again? This is not about blame. This is all about how can we address what was brought to us, dissect it, find out the root cause, and move forward to correcting it. So at that point, we will go ahead and break. I'm going to ask the board, do we want 30 minutes, 45, an hour? What are you guys needing?
Well, we have two other items.
We have two other items after this. This one here, we still have a lot to cover. Maybe 45. 45? Okay. Board moderator, we are going to go on a lunch right now before I dive into the next sections. This is actually a good breaking point. Thank you. And we will return at 12:45. Thank you. Okay, thank you, everybody. We're coming back into session. It is 12:45, and I will turn it over to our board president
This meeting is being recorded.
to establish a quorum so we can open back up.
All right, let's establish a quorum. Dolores Trujillo here. Board Member Allison Cormack,
Cormac, present.
Board Member Jovita Dominguez,
Dominguez present.
Board Member David Lawler,
Lawler present.
Board Member Patricia Nguyen,
When present.
Board Member Neelu Patel,
Patel, present.
and Board Member Vicky Granowitz.
Granowitz present.
Quorum has been established.
Thank you. So I will pick back up and we'll continue to go through the report. The next section that I'm going to going into is going to be the nursing support group facilitators. Understanding that the nursing support group facilitators are something that the intervention participant has contact with on a very routine basis. It's typically about one time a week. They spend a lot of time in there. They really enjoy them. But I need to make sure that our board and our public understand that they are not a part of the BRN. They are not a part of Maximus. We don't have any choice in who they are. They are contracted through Maximus. They are not contracted through us. Nope, contracted through the board. Shannon's looking. Oh, they're not contracted at all. Thank you. So she's clarified that. Thank you, guys. So they're not contracted through the board or Maximus. That is my note, much better. Yes. And so with that, there are requirements that they must meet. And we are now doing an evaluation to make sure that those requirements are met. There are some thought that maybe some nurse facilitator groups may not have the appropriate person in there based on requirements. We don't know that right now. We are doing an evaluation to make sure. But there is something that I really wanted to make sure that everybody knew is that the nursing support group facilities set their own pay. We do not. Maximus does not. Each individual one sets their own pay. And one of the nursing support group facilitators charge no money. So there is not a requirement to charge. So when we're talking about what the pay is for participation in there, there's one group that is free of charge. And they chose to offer their group free of charge because they wanted to give back. And I think that really speaks to the variation when people say, well, I've had to pay this much and I've had to pay this much, and why is this one paying less? Those are some of the considerations. We're looking at testing, we're looking at providers, we're looking at nursing support groups. One of the other things in nursing support groups is they're not held to Bagley-Keene, obviously, right? So they're not a committee of our board, they're not anything, so they can meet and they can interact, and they provide a lot of input. One of the things that we heard previously is that they were providing recommendations. And that to me is something that when we looked at it from a legal standpoint, that CCMs, case managers, nursing support groups should not be providing recommendations, but what they should be providing is information. Information to the providers that are part of the IEC committee for them to evaluate, to be able to make determinations on the person's progress in the recovery program. And so that was something that was stopped, is asking for recommendations, soliciting recommendations, and allowing for those recommendations to be taken. The information they provide is very important. The information that they provide is vital in truly understanding what's going on with the participant, because we see them, and I say we as the greater we, not we as in me, but we see them from the board through the IEC, and that could be as little as once a year. And so the IEC committee, if they're only seeing this participant once a year, they need that feedback. But again, it's not to make a recommendation. It is to get information for the IEC committee to make recommendations. And that is specifically spelled out in law. And that's something that we need to make sure that we follow. The one thing that was suggested that had previously happened before, and so I looked in to see if that's something that we can support, is can we get nursing support group facilitators all in one room on an annual basis to kind of discuss best practices? And yes, we absolutely can do that. And I think that's something that we can do moving forward. Because they are not a committee or a subcommittee of the board, they do not have to follow Bagley-Keene. So we can get them all in the same room. It can be confidential. It does not have to be publicly noticed. And we don't have to worry about navigating through that process and having some sort of information spilled out accidentally that should be remained confidential. We want to protect our intervention participants, but we also want to make sure that we get everybody on the same page. One of the other things I ran into discovering is there was not an understanding from the committee that they could require a single person to manage medication. So one of the issues that does come up is that you might have a person that shops for medication or has 4 or 5 different physicians or nurse practitioners that they go to seek medication from. And not necessarily are they trying to deceive, but when you have one person that's managing, psychotropic medications or something, and you're not aware of what the cardiologist is doing or the pulmonologist are doing or whatever, you need to have one person kind of managing. That is not a mandate for our intervention program, but it is something that can be offered. And that is something that our staff are putting out to the IEC members to see if that's something that they would consider based on the individual needs of the participant. One of the other options that were kind of discussed was previously done was when a intervention participant was accepted into the program, they would have an IEC committee member that would volunteer to be their one-on-one mentor of some sort. That's not supported. An IEC committee member is in lieu of you all, right? If we didn't have the IEC committee, you guys would be doing our IEC committees. And so this is a committee that's been appointed to do the work for you guys, to evaluate the participants' progress through our intervention program. To have one person connect with a participant on admission and follow that participant through really blurs that line, and that's not something that we could continue to support. One of the things that was a benefit of that was if something occurred in between IEC meetings, there could be something where Maximus, the vendor, could immediately reach out to, or the program manager for BRN could immediately reach out to. And that was utilized. So in looking at what could be done, there is an option that could be considered, and that is IEC committees are bound by Bagley-Keene, right? You could create a subcommittee of 2 of an IEC committee, because 3 constitutes quorum, that could be assigned by subcommittee. So if we have 10 IECs, there could be a subcommittee of 2 at every IEC that could meet on a regular basis, that could look at items that pop up with the people that are assigned to their subcommittee to be able to make some decisions, to look at things, to provide that expert consultation. The requirement, like with any subcommittee, would be that they would have to report it out when the next IEC met, and that everybody would have to know exactly what occurred and what the decision was. And if voted on, that would stay. If voted that they didn't agree with it, they would have to go back and fix whatever was done. So that could be something that we can look at moving forward. That is not something that has been solidified, but that is something that we would like to look at to see what we can do to be in compliance with Bagley-Keene, make sure everything's reported out, not have a single person serving as that person on the committee, but then also being able to be there in a timely fashion to get people through. So that is something that if we did, we could vote on that in upcoming IECs. They would vote on a subcommittee, they would have that established, and we can move that moving forward. And I think that's something that we'll discuss more within our IEC, within our enforcement, and see where we can go with that. I think that was it. And so we'll go over that. Oh, one more, sorry, just on this section. The other option, the other discussion with participation with IEC members was the clinical case managers at Maximus. And previously, they would come in, very similar to the nursing support group facilitators, and make recommendations on the participants' plan and such. And that, again, is something that has been refrained from, and really kind of streamlining that process, that they shouldn't be making recommendation, but they absolutely can provide input. And so we want to make sure that that is very clear. Please come in, please answer questions, please provide input, please be there in support of the IEC, of the IP member that is with you, because when talking to various people, that IP intervention participant in front of an IEC feels like you're going in front of a court of law. Anybody that's ever been in front of a court of law, you really want that lawyer. You really want your lawyer that's standing there that you can ask questions to, so that you can know what's going on, so you know what's to expect. And I think that's really where that CCM can serve in that manner, is to be a resource for the IEC committee, but also a resource for the intervention participant without blurring that. And so if the IEC committee is not asking for recommendations from the clinical case manager, but asking for input on where they believe they are through the process, I think that could be managed. With the intervention participants, what we heard a lot in public comment was, I don't know what to do. I don't know what to expect. I don't know what's going to happen. I go in front of IEC and I don't know what this means. That clinical case manager, if managed that role well, could also do that and say, you know what, you're going to go in here, you're going to see a panel of at least 3 people. There might be 5 people. They're going to ask you questions on this, this, and this. Please just be prepared to ask. You have the ability to respond to that. You have the ability to provide information. You can go through that, because right now it was a stark departure from what used to happen, where they'd come in with them, they'd answer all their questions with them, they'd coach them, and then they would provide recommendations. And so in order for us to stay inside our law, providing input, absolutely needed. Recommendations, again, the IEC needs to do that based on the assessment information and not recommendations. So I think we can manage that. I think we can come to a balance on that. The clinical case managers that I talked to really were missing that part. And they really wanted to feel like they were able to elaborate on what's going on with that participant. And I think that they can, minus the giving of their opinion on their progress and their recommendation. And so I think that we can balance that. And then hearing the public commenters say that they just need to know what's going on, I think that person can serve in that role. So those were some of the big things with that. So I just want to make sure that I pause here for a minute before I go into the next one. No? Okay. So one of the other big things that was talked about was transition. And yes, that is not in law. There is nothing in law that says that there is a transition. But in our contract with the vendor, the word transition is all over the place. And so transition happens typically going into year 3. So year 1 is the most testing, the most in contact. Year 2, they're working, their testing's decreased, the contact's decreased. Year 3, they're just trying to, as some of the things that I heard, bide their time to get out. That's not necessarily a bad thing, right? You're maintaining the status quo. That's not necessarily a bad thing. I think what happened with transition is it was an automatic. You know, at the end of the 2-year mark, you got transition. At the end of that mark, you were successfully completed. And in fact, they were put on the schedule in different colors for successful completion, not put on the contract on the schedule for the IEC that says requesting completion, so that the IEC can then evaluate and say, yes, I believe everything's met, they can complete. So what was discovered is they were putting on there saying that they were going to complete, and there was actually celebratory processes around that completion, which is not necessarily bad, but they would bring people in, sponsors, nursing support group facilities, be present with them on that final day. I'm all for celebration, but what was discovered when talking with various stakeholders was the thought was if they were put on for completion, that was what was necessary for them to do. And so again, it wasn't part of an evaluation process, which is what we needed to maintain that to be as an evaluation process. And so we would love to find a way on how that could be celebrated, how that can be done, how people can be brought in to be successful completions without it coming forward for, yes, they're going to successfully complete. And that might be where that subcommittee can come in handy as well, is that subcommittee may be able to meet in advance with all the people that are anticipating completion, review it, say, yes, I believe that's going to be the recommendation, and then they could be scheduled for completion so that they can have that celebration. It is very important for people to celebrate milestones, to have something to look forward to have something to work forward to, and have a basic understanding of what's going to happen, especially if they're waiting to kind of save their life around that and plan that. So they can celebrate that. They can then do that. And so understanding again that IEC is a recommendation to the board. So the board will have to review that. But I think that's also going to come in when we do that subcommittee work, is that subcommittee could meet with a board liaison. I'm able to meet with the subcommittee of admin every Tuesday. And so I'm able to kind of know what to expect, and admin knows what to expect. And we're able to kind of work that out. So I think that if that is managed correctly, some of these things that were really something that drew the participants to, we could still incorporate. But we can also maintain that it's not a guarantee, and that this is evaluated and this is a process that's reviewed. So those are things that we could look at with that. I think I covered that. Okay, couple things that were brought up for discussion that I'd really like for the board to consider these is major and minor violations. So I'm pulling up my uniform standards, and I'm going to read through these for you guys to take into consideration. And then if you guys want to discuss further, I'd be happy to. Uniform standard number 10 says the Senate Bill 1441 requirement says specific consequences for major and minor violations. In particular, the committee shall consider the use of deferred prosecution stipulation described in Section 1000 of the Penal Code, in which the licensee admits to self-abuse of drugs or alcohol and surrenders his or her license. That agreement is deferred by the agency until or unless licensee commits a major violation, in which case it is reviewed and the license is surrendered. And so then a list through major violations. Major violations are failure to complete a board-ordered program, failure to undergo a required clinical diagnostic evaluation. I want to touch bases on this one real quick. The IEC members make a recommendation at times for an evaluation. I need them to understand that that is a recommendation, that is not a requirement. So what happens, I'm told in various meetings, is that they made a recommendation for evaluation. They came back and that was not done, and that they were considering putting that person in violation. But understand that everything that comes from an IEC is a recommendation. It is not a requirement. So if you are recommended that you get a some kind of a diagnostic assessment, and it is found to be too expensive, it is found to be not available, the option is that IP participant can come back and say, I have not been able to find it. I cannot afford it. Is there an alternative? And then the IECs can consider an alternative that may be able to give them the same information that they're requiring. It might not be, the best of the best, but it is something that they can settle on. And so I want to make sure that everybody understands that failure to undergo a required clinical diagnostic evaluation is different than failure to undergo a recommended clinical diagnostic evaluation. The other ones on there are called multiple minor violations, and then treating patients while under the influence of drug and alcohol. Any drug or alcohol related act which would constitute a violation of the Practice Act or state federal laws. Failure to obtain biological testing for substance abuse. That's our missed test. Testing positive and confirmation for substance abuse pursuant to Uniform Standard 9. And knowingly using, making, altering, or possessing any object or product in such a way as to defraud a drug test designed to detect the presence of alcohol or controlled substance abuse. The consequences under this one are order to, cease practice. Licensee must undergo a new clinical diagnostic and evaluation. The licensee must test negative for at least a month of continuous drug testing before being allowed to go back to work. It could terminate the contract. It could be a referral to disciplinary action, up to revocation. And then we go into minor violations. And minor violations are untimely receipt of a required document, an unexcused attendance at group meetings, failure to contact a monitor when required. And those are our check-ins they had brought up, right? They said, I'm checking in and I missed a check-in and I was kept off work. Another one is any other violations that do not present an immediate threat to the violator or to the public. And that threat to the public or the violator is determined by the IEC and the program manager at the board. And that is not an 100% across the board thing. It's not like if you do this, this is a threat. if you do this, this is a violation. It is an assessment. The consequences for a minor violation is removal from practice, practice limitations, required supervision, increased documentation, issuing a cite or a fine or a warning notice, requiring a reevaluation or testing, or other action as determined by the board. What has been brought up to me that they would like to have discussion, I've heard this from my board staff, I've heard this from Maximus, I've heard this from IECs, is how we manage a relapse versus a slip. Now, the differences that I've heard with a slip is that it is a single occurrence. It is a return to addictive behavior, but it is not a relapse in that they're using. The reason that this became quite a item for more discussion and more evaluation was brought to me by our board staff as well as Maximus is there have been people on admission in the program receive a packet of forbidden medications, essentially. These are all medications that could pop positive, that could be received over the counter, but that could end up with a positive drug screen. Typically, you can get what's called a prescription positive, and that is where a physician or a provider orders the medication, you take it, it's okay. We had one that showed up in the media where I believe they were in labor and delivery, and they popped positive afterwards. I would fully expect that to happen. There are pain medications given, and rightfully so, but that is done saying, hey, yes, I popped positive, I had a child, and here's my medical records, and this shows why I'm positive. The same thing happens is, yes, I was positive, I have a prescription for this, I'm going to be positive for this. Those are not violations. They're not minor violations. They're not major violations. They are supported by the medical documentation. Where you get a gray area is if you take a medication and you don't have a prescription, but you have a recommendation. The provider says, well, I recommended this. Is that to be treated as a prescription where it is null, it doesn't affect it negatively? Or is that something that it's a recommendation, you know the list of medications that you're not supposed to be taking, you have to be held accountable to that, and you chose to do that anyway. So we don't have a clear answer for that. I can tell you AA says any use resets your sobriety date. Other community groups say, no, that sobriety date is huge. It does not reset a sobriety date. And in fact, that was a recommendation. That was a slip. They could maintain their sobriety date and move forward. The reason that this becomes important is successful completion of our program requires 3 years of continuous sobriety. And so say you're 2 years in, you take one of those meds on a recommendation by your provider, should that reset your sobriety date and require you to now be 3 more years in. If on evaluation something is found and you say, oh, I reviewed this and I look and a year ago this happened, we set the sobriety date, we then lengthen you by a year on that review. Those are things that have been brought forward to me both from board staff in support of and in opposition of, both from Maximus that has shown support of and opposition of. I don't have a clear answer on that. I do understand that it's going to have to be a case-by-case basis, but I want to make sure that the board is aware that these are some of the issues that are still outstanding, and I don't know that we have a clear path forward on that. Anytime that you're lengthening a program by a year, 2 years, 3 years, I think requires multiple evaluations, right? I don't know that that should be something that is just stamped and moved forward. Not saying that that's occurring right now, but that's an area that still I think is unclear. So as it stands right now, a couple items similar to those described have occurred. They have changed the sobriety date. They have lengthened the state in a program. I think at that point, what other boards and bureaus, when I've talked to them, has done, and I can't say that I want to take this on, but I am telling you that this is an option that other boards have put forward, one of them being Board of Pharmacy, is that if the IEC members make that decision, it is reviewed by the program manager. When the program manager sees that it is any kind of substantial length in program, that gets an EO review. And the EO review at that point can say, I see that all the documentation is here to support this. So that's defensible, right? And it's not arbitrary. It's not saying that I don't agree with that decision, right? I want to make sure that's very clear. Is an IEC that has a physician, nurses, a public member made that choice. But if during that evaluation, there is not ample evidence to support that decision, that we can recommend to go back down to IEC and obtained that documentation. And if that documentation is not able to be obtained, then that would constitute another route. So keeping that decision at the IEC level, but getting that review to make sure that it doesn't get missed and we have the documentation to support that. That was one of them that is still outstanding. When speaking with legal on that, the request was to make it very clear that discipline goes in front of a judge and they present evidence to constitute that discipline. This is an alternative to discipline. This is that evidence that has to go in front of a committee. It is similar processes, but it all is based on evidence. Yes.
I'm sorry to interrupt you. I have a question
Please.
there, just based on that. When you do go to a court of law, one of the things I believe that can affect your sentence is mitigating circumstances.
Yes.
And so my question is, based on the hours of public comments we've heard, it seems as if more often than not, in the past, the IEC saw a slip or saw an action and just thoughtlessly went, you're disciplined, instead of, like you're saying now, evaluate the evidence and determine that it's possible you don't need to be punished because we get it.
Mhm.
Are you saying the IEC has the authority to think so that they can make reasonable decisions based on the mitigating circumstances, for lack of a better word,
Yes.
that they're going through now? Okay.
Yes, and so we will be doing a lot of training on that to make sure
Okay.
that that is clear. One of the things is we right now have our staff members. We have about 3 staff members that attend every single IEC because of the changes that have been put into place. And my staff as well, want to taper out of that. That is a lot of time and a lot of effort. And I know that that's not always seen as a positive thing. One of the things that was also reported is it looks like because of the board presence there, that the members may, or participants may believe that it is being seen as the board is leading, right? And so we want to make sure that we balance that. And so it doesn't look like the board is leading, but that the board is ensuring that the changes have been put into place appropriately. It's kind of following through on that change process, right? Where you're setting it. So we will work after we do more training to decrease the presence of our board at those meetings. We will go from 3 down to 2, down to 1, down to potentially even at that point doing spot checks versus having a person there monitoring every bit. But that's going to come through time and training. But our IEC members absolutely have the ability to determine what a minor violation is and what the outcome of that is. And that is not a requirement to change like a sobriety date if that is what the evidence suggests, right? And so that is something that we need to make sure to make that clear. And that's why I believe anytime that we lengthen the program, that was one of the biggest complaints is you're moving the goalpost, right? That was one of the things we heard all the time in public comment was we're moving the goalpost. If at any point that goalpost is moved, it does require another review. And that has to be supported by evidence. That way it is not seemed as arbitrary. And if at any point we look at it and say, you know, I don't have the evidence that supports this, we can kick it back down for another reeval. Talked about that one. Got that one. One of the other things that was talked about with IECs is that they're requesting that IECs be trained on bias. Yes, all of our IEC members are required to have a history in substance abuse and mental illness. They are required to look at the various aspects of a recovery program, but that some of them may still have some old ways of thinking. And the request is that there is training on new ways of thinking, new language, because sometimes it was shared that even some words that were used in interacting with the participants or afterwards could have been seen as inflammatory, could have been seen as something that was not supportive of recovery. And so again, I was not in those meetings. I do not know exactly what occurred, but I think any time that we can address this through education, re-education, anything that we can do with looking at DEIB or looking at bias, I think that's something that we absolutely can do. And so that would be another one. And so I think that answers most. I do want to add a couple things that we did that I believe was received as very positive and were not controversial at all. And that is now the BRN provides cures reports to the IEC members. Cures reports show a listing of Schedule II meds, et cetera, that a participant may look at. And so instead of just getting a personal kind of report as to this is what I'm doing, we now have a cures report to help substantiate that. And we also have, if the IEC ordered it, a medication person, single provider that's kind of monitoring that. And I think that is helpful, especially when you're dealing with multiple types of substance disorders, substance use disorders. The other one that was, I believe, really a positive factor was utilizing and sharing out our reports. When we get complaints in, when we did this as an alternative to discipline, those complaints were not turned over to Maximus and it wasn't part of the system. And so Maximus, when they were treating the participants, were treating the participants only on I have a mental illness kind of report, or I have a substance use disorder kind of report. And they didn't understand the full breadth of it, is that you had actually violated the Nurse Practice Act, or you had a DUI where you were at a 0.16 level and you had kids in the car, et cetera. Like there was multiple, as you put, David, mitigating factors. And Maximus didn't have the full picture. And so we did our due diligence looking at that on what we can do to provide that picture. And so sharing that information is there. I think I'm just looking at this. One of the other really positive things that our board staff are doing is they created a checklist. And in this checklist is all of the items that can be altered by the IECs. And so when the IEC sees a participant and they're making a motion, our board staff will say, do you want to adjust the testing frequency? And they can say yes or no. Do you want to have a provider monitor medication? Yes or no. The IEC committee members were saying they were having a difficult time understanding all of the things that they could address. And they were having a difficult time understanding what they could or could not address. And so it wasn't just a memory aspect, it was just they didn't have the understanding of it. So our program manager created a form that allows for every item that is within law that can be addressed. And when they're making the motion, they will go through utilizing that form to make sure all aspects are covered. And that therefore it's a very thorough recommendation that comes from the Intervention Evaluation Committee. So that one there is great. I think that was a huge positive. And I think we're wrapping up here, except for the one thing that seems to be the item of discussion that has been really, really looked at. And that is the direct patient care requirement, as well as the passing narcotic requirement. And so I'd like to have a conversation about that and really open it up to questions and stuff from board members here, and really look at what we can do to look at that process that was put into place and what we can do to address that. So part of successful completion is in alignment with uniform standards that says, and I'm going to pull it up so I can read it to you so it doesn't look like I'm just shooting from the cuff here. There we go. Uniform Standard 12. So Uniform Standard 12 says, criteria that a licensee must meet in order to petition for reinstatement of a full and unrestricted license, understanding that that is what our board has, is a full and unrestricted license or no license. There is no in between. So Uniform Standard number 12 says petition for reinstatements are used in this standard is an informal request or a petition as opposed to a petition for reinstatement under the Administrative Procedure Act. The licensee must meet the following criteria to request or petition for a full unrestricted license. 1 is demonstrated sustained compliance with the terms of the disciplinary order, if applicable. 2 is demonstrated successful completion of recovery program, if required. Number 3, demonstrated a consistent and sustained participation in activities that promote and support their recovery, including but not limited to ongoing support meetings, therapy, counseling, relapse prevention plan, and community activities. 4, demonstrated that he or she is able to practice safely. And 5, continuous sobriety for 3 to 5 years. That continuous sobriety we kind of already touched on, whether or not that a slip or a minor violation should reset that. And the other one is demonstrated that he or she is able to practice safely. And this is where there's been a lot of controversy around that. Is can that only be demonstrated through direct patient care? Can that only be demonstrated through passing narcotics? And the answer there is not so easy because yes, sometimes that is required. An example that was used for me that really kind of brought it home was if I'm a nurse anesthetist and I am in this program, my job is direct patient care, passing narcotics. That is truly my job. So I would have to work in that environment to be able to show that I can practice safely. That one there, that was something that was used right up front with me. And I said, okay, I can understand that. That I could have some evidence that would support that. I would look at your CV, I'd look at your resume, I'd look at your license, I would look at your history, and I would be able to look at that. I was also given the counter of that. And the counter of that is absence of substance use disorder and absence a mental illness. This person was and has been a safe practicing nurse. They took the NCLEX, they passed the NCLEX. It says they were safe to practice. We licensed them based on the education. They have the scientific knowledge. They have the technical skill. They were, until this, a safe practicing nurse. That is different from somebody that practiced unsafely by violating like gross negligence or incompetence, those kind of items where I hung blood on the wrong patient and then lied and said I did hang it on the right patient and it wasn't discovered until later and there was a death or something. So there are many different factors that need to be taken into consideration for that. What was also presented to me during that time frame is the cog in the wheel was the mental illness or the substance use disorder that was causing the unsafe practice. And if you address the mental health or the substance use disorder, then you still have your safe practice here. And so that is where I think that we need to look at the board is what do we want to see come from that? The ask from one of our prior board members in May when this was brought to us was to immediately rescind that process, to say, do not require direct patient care, do not require narcotic passing and move forward. And that option is on the table here for discussion, absolutely. my ask is that again, it continue on a case by case basis, that we do have some ability, because it is supported in law, that we have that ability to, and we look at this on a case by case basis, and it gets that review up and it gets kicked down. But it is also was brought to my attention with doing this deep dive that around January of this year, there was some miscommunication or misinterpretation where it was blanketly applied, and that was not the ask. That was not the ask of our board. That was not the ask of Maximus. That was not the ask of the IEC. And so I think in those cases, I do think that we need to make some action on that. I would think that we could look into how many people were specifically affected by that and potentially look at what we can do to rectify that. So with that said, some of the other factors that come around for that is, can we determine safe to practice without them being in a direct patient care? I met with experts from NCSBN. Some of them were on our call yesterday. I met with experts in addictive behaviors and mental health. And they've all shared with me that they do not have evidence that says you must do direct patient care, you must do narcotic passing. But I think you also need to look at the situation that got you there. And I think that it has to be a comprehensive evaluation. And I think must is too strong of a word. I do believe that there may have been some opportunities where this was interpreted incorrectly and people were put into practice situation that couldn't be feasible. One of the examples that I heard were motions that came out of IECs were work your part-time position that you've been doing, but then add an additional day in direct patient care. We heard that many, many times throughout here. And again, I ask you guys to look at some of the factors with that. Can that be possible? We've seen it happen. We've had people successfully complete since this was brought in our attention. And we've had some of the people that have successfully completed say, this really helped me. This helped my confidence. I feel better going out. So it wasn't across the board a negative thing, but I can't say across the board it was a positive thing either. So one of the other things that I looked at were people that were affected negatively by this, who were working 2 days a week, doing the nursing support group, doing the other community groups, taking the test, and then asked to pick up yet an additional job. And picking up that additional job that they may not have been in direct patient care for a while is a very difficult thing to do. And I used to be a hiring manager, and I'm going to tell you, just from a hiring manager standpoint, I would not have hired them. They don't have any direct patient care. I have to invest $30,000 to orient somebody to a new specialty that I know they're going to leave in 6 months because this is not something that they want to do. So those are all things that I think that we need to look at from a just culture perspective that says, is this something that we can continue with? If we do want to continue with it, what is our review process for this? And if we don't want to continue with it, what kind of impact and unintended consequences that might have? Because ultimately it does come down to protection of the public, and what does that mean to us as a board? So I'm going to pause at this point and answer any questions that you guys might have. Yes,
They're comments more than questions.
go for it.
Except for maybe one, which is going to take me back to something you said earlier. But my comment based on what you're saying now, 3 things. First of all, I appreciate the idea of this not having to be a uniform enforcement for an action and it being able to be case by case basis. That's a good thing. In my mind, I'm still hearing public comments, and I say to
Yes.
that, and I still say to that, but even in a case-by-case basis, there is someone in an IEC making a decision. And I know I'm repeating myself, beating a dead horse, and I don't need to say it again, but I would like to trust that those people are using common sense and thinking about these people as people and not Uniform Standard number 12.3.8.c. Number 2, And again, just to comment, and I know this is radical and ridiculous, but I was wondering if there is any other rubric besides standing rules that other boards are using to discover discipline or enforcement options. If these aren't working in our situation, for example, and this is my last comment and point, when I go back to standing rule number 10, like you said, number 6, failure to obtain biological testing is a major violation. It doesn't say in that sentence by midnight on July 3rd.
Correct.
And so I would like this not to be interpreted, and if it's going to be interpreted with common sense. So that's all. I have no real question. Those are just my comments, but I want to take a moment, because I don't have anything else to say, to thank you for the amazing, thorough, comprehensive, and productive work you've done to make these changes. I'm impressed and happy and glad to hear it.
Thank you. And David, I mean, that suggestion is perfect. These uniform standards are used by the 8 healing art boards. They are law. We do have to follow them. It comes down to how they are interpreted. And it does say failure to obtain. What we've had people do is obtain by the next morning. That sometimes is something that's considered. And so if you do get what is considered a major violation, and there has been conversation with the Maximus director, our case manager, if maybe we can put in that subcommittee that we kind of talked about into there, then maybe at that point, that could be something that is absolutely considered, because it is, instead of 24 hours, it's 26 hours, right? I think that knowing more what we've heard, especially with Vault, knowing that there are many regions that don't have a site in them, knowing that we haven't fully implemented the saliva testing, I think there is room for consideration.
Thank you very much. Lori, thanks so much for your hard work on this, and thank you to staff too. I know how much work has gone into this. Hearing this report, which was long and detailed, but which reflected answers to the comments we've been hearing for months. So I appreciate that very much. You've done a lot. We have a lot more to do.
We do.
But I do think systemic changes were made in the last several months, which were made in good faith and with an eye to public safety. And I don't want to belittle that. That is really where it was coming from. However, they were applied too broadly, and I don't think anybody would argue with that. I know staff talked about it. Maximus talked about it. I haven't talked to the IEC. With all of this in mind, I don't think we need to roll back some of these changes. I don't think some of these changes should be the only obstacle between completing a program. So with that in mind, I have a motion, and I don't know if it's premature because I don't want to cut off conversation by board members.
Let's find out if there's any other questions.
Okay.
Any other questions or comments from board members?
I think Allison.
Allison?
Thank you, Chair Trujillo. Thank you, EO Melby. I don't think I can write quite as quickly as you speak, but I got most of it. I guess I'm interested in the subcommittees for the IEC. Would those meet in public the way the IEC does or not?
They would not, and that's what subcommittees do. So
Okay.
when we have our advisory committees and we have our board committees, we can have subcommittees of each one of those that can do work in between. An example would be when we were appointing members to the Nurse Midwife Advisory Committee. So we came into the board, we asked for a subcommittee. They voted in 2 people that would do the interviews, that would do the review of the people that wanted to become an advisory member. So they did the work, they made recommendations, and then they came in front of the board and said, we recommend this person to be put here, and they went ahead and did that, and that was the vote. And so that allows for work to be done in between, but then brought forward to put it out in a public context so that nothing is not public, but we are able to do work in between the meetings.
Yeah, it's working.
One thing really quick
very
that
well.
this just triggered me, and I'm so sorry, I forgot to mention this, is how we appoint our IEC members.
Right.
It was discovered that previously our IEC members went through an interview process. That interview process was done with board staff as well as Maximus staff. They interviewed IECs and then made a recommendation to the board based on that interview. There was some that said a board member was present. There was others saying that board members were not present. I haven't got a clear story because that happened in the past. What occurs now is that there is no interview process for IEC
Yeah,
members.
I remember asking about that the
Yep.
very first time we voted on it.
Yep. And so what happens is we put out the application, they fill out the application is reviewed, the resumes are reviewed by staff, and then based on that review, a recommendation is put forward to the board. You guys then get that information review as well, and then you make a recommendation whether accepted or not. So I wanted to answer that question for you. There is currently no interview process. That could be something that could be reinstated. That is a request from you guys because again, these IECs are appointed by you. It could be done by a subcommittee of this board. It could be done by a subcommittee of the
EIIC, yeah.
EIIC committee. It could also include a subcommittee of the IECs because they know the job better than anybody
Right.
else.
Yeah.
So that's another use that a subcommittee of an IEC could be utilized for. So just want to put that
I'd
out
be
there.
very supportive of having a formal interview process for members of the IECs. I think, it's be an opportunity to share the importance of the role and the training expected, et cetera, et cetera. So I would be supportive of that. I guess the follow-up is, when you mentioned the IEC subcommittee, is that in the context of getting things done more quickly, or was that to sort of be like, we'll have two subcommittees maybe, and this subcommittee will have half of the participants and the other subcommittee will have other half of the participants? Like, is this meant to be the personal touch, or is this meant to be we'll speed the process along?
They can't have the personal touch.
Okay.
I know that's something that was really, really wanted, but you have to have that separation.
Totally
They're-
understand. It
yeah.
just wasn't abundantly clear from your description earlier. So it's really intended to be a sort of, again, just to read this back, transition is not automatic. It has to be recommended. The subcommittee could look at that, schedule it, and then the person could, have a, not an assumption, but a hope,
Yes.
but not an expectation that would happen at the next meeting, and they could, okay. All right, so that makes sense. I mean, it's always, frustrating to add what can be perceived as bureaucracy and more time, et cetera. And this will be an additional, responsibility for members of the IEC. We will have to probably think a little bit carefully because there's 3 different roles, right, on the IEC. There are 3 nurses, a physician, and someone who works in the therapy community. Is that right?
A public member.
A public member. Okay.
With knowledge.
Yes, all of them
Yeah.
with knowledge.
So we'll have to think about if we do those, whether or not that's there. I'm definitely supportive of that. I will say, just a little thing on when you went back through the minor violations. We heard I failed to check in and I had to be off work for 30 days. It is possible that would have to happen under certain, facts, but it's not required.
The 30 days off is not. It actually doesn't follow. And
But
so
practice
the
limitations is
the
one for,
practice limitation should not be imposed for a minor violation.
okay. Okay, great, thank you.
Okay, hearing no further comments, I move that we direct the EO, Ms. Melby, to work with executive management team and the intervention program manager to, number 1, suspend the imposition of the requirement that participants work in direct patient care. And number two, suspend the imposition of the requirement that participants work passing narcotics in order to successfully complete the intervention program. And then I have an unless, and it's a big unless. Unless there is additional evidence of patient safety issues. Additionally, if there is a request outside of the norm that these be imposed, and these requirements are imposed, the EO must approve the requirement prior to imposition. So in other words, if there is a safety issue that is in evidence, and one of those two things are going to be imposed, they have to kick it upstairs to the EO
And-
to impose that.
And that, just to clarify, that's for review that there is
Additional safety issues.
an issue and that we have evidence to support that, right? Okay. Okay.
I second David Lawler.
Great. So before we go to public comment on that, I would entertain any comments from board members.
I'm not a board member, but can I have comments? Because I have to do this now. Okay. So timeline. If I will have to pull a report to find out participants that were affected by that. So clarification for me is participants that are in the program right now that should have completed or could have, I'd like to change that could have completed, that had this request, you're asking me to review that. And if there is no evidence to support that request, that we then successfully complete? Is that what we're looking at, or put them in front of IEC for consideration for successful completion?
Thank you for that clarifying question.
Because I'm
Yes,
trying to
I
think
would say-
process wise.
I would say put it back in front of the IEC on an expedited, manner if we could.
Okay. Okay, so I'm just trying to wrap my head around this. Sorry, I'm just trying to make this a path forward. Okay, so pull a report from Maximus, find out who was in transition during this time period. We're looking at probably the last 8 months to a year. Look at anybody that had a requirement for direct patient care or narcotic passing. If there is no evidence that supports that, then I put that list together. We get them in front of IEC. IEC then considers them for completion. If IEC looks at it and says, I have concerns, I then bring that back to our board and say, we put 12 people in front, 10 people were completed, 2 people, IEC still had concern. Here's my evidence. And those will continue in the process.
Yeah, that would be great. In fact, I was going to ask for a
Okay.
report back at every EIIC committee.
EIIC, okay.
Yeah.
Okay. And then, when you're looking at timeline, it is a manual poll. I know we do have an IUC committee next week. I could look and see if there's anything, I can't guarantee that, but I can look at projected ones. I think the big thing that we want to take into consideration with IEC meetings is they typically have an IEC that they're familiar with, that they have had some understanding and interaction with. I would like them to try to stay as consistent as possible because they have the background. But I would also want to expedite this for you as much as possible because we have heard from public comment that this has greatly affected the lives and we want to show some action. So I will do what I can to get them in and I will see what kind of report I can pull. It is Thursday. I will get a meeting on my schedule with Maximus tomorrow to get a report. And then I will start to manually go through that. And we'll see how soon we can get them on and then I will report out. I know I have a lot more questions. They're just kind of swirling around in my head, but I think we'll go to public comment
and
as
then-
I kind
but
of work
do
this
think
through.
There was a question over here.
Yes.
Board Member Cormack?
Is it possible for you to restate the motion? Because you said some things and then there was an additional thing and then there was, so it'd just be really helpful to get it buttoned up.
Well, I wrote it, so I can, of course.
Or can you just read it
restate
again?
Yes, happily.
Great.
But if I have missed something, I'm just asking that it be filled in.
I'm going to ask really quick for board moderator or staff to help me with this. As Tricia reads her motion or states it, if I can have board staff kind of document what that is, I would love to, as we go out to public comment, be able to put that up as a slide, that this is the motion that is on the floor, so that everybody understands that we have a first and a second with this motion. And because I assume public comment is probably going to be fairly lengthy, I want to make sure that that is up there. Yes. Yes. Yep. Okay, bear with us. Matt's helping out, coming to the rescue.
I'm going to be happy to read this again, and then I have terrible handwriting, but I'm going to give it to Matt to type. I'm a I'm just going to say I'm left-handed. So here's my motion. I move that we direct the executive officer to work with executive management team and the intervention program manager to, number one, suspend the imposition of the requirement that participants work in direct patient care, and two, suspend the imposition of the requirement that participants work passing narcotics in order to successfully complete the intervention program, unless there is additional evidence of patient safety issues. Additionally, if there is a request outside of the norm and these requirements are imposed, the EO must approve the requirement prior to imposition.
Thank you. So we're going to pause. We're not going out to public comment yet. We will. I want to make sure that this is typed up and on the screen. And then as we do this, I want to do some kind of setting kind of expectations. It is going into 2:00. It might be good for us to take a 15-minute break at this point, so we can break until 2:00, so that our board members have empty bladders and we're ready to do this. Take a little breather, because we know that this has been a very emotional time for many of our participants that have been involved, and we want to make sure that we're able to answer that. The other thing that I want to put out there is that board member Tricia Nguyen had shared with me that she does have a hard stop at 3:00. So she will be leaving for the day at 3:00. We do have a hard stop at 5:00. Our meeting is scheduled till 5:00. We will not be going past 5:00 today. That is in respect of public, of staff, of our board, of ourselves. We do need to end right at 5:00 today. And additionally, there is going to be a 2-minute limit to any of the comments that come in. There is not going to be a repeat. So if Nurse A spoke earlier in public comment and say something was sparked by somebody and another Nurse A wants to jump in again, that cannot be done again. So Nurse A gets one comment. Another one that is very commonly done within government is you cannot take a minute of your time and then give a minute to your friends, so they have 3 minutes. And so I wanted to make sure that that's very clear as well. And then one additional item that I want to make clear before we go out and we're going to take a break and come in and do public comment right at 2:00 is understand that we're not done. This is a first step. This is to answer the most dire process that was put in place, that people have said that they've been considering, suicide and maybe not being an RN anymore, et cetera. So we wanted to address that. I hope that our public has been able to see that we've heard you. I specifically made references back multiple times that we heard this in public comment. I've looked at this and this is what's occurring. I've looked at this and this is what's changed. So please know that your public comment matters, that you guys matter, and that we want to hear from you. But in order for us to hear from you and get things done, we do need to have these limits. And so I really appreciate you guys are respecting those. And last but not least, we have 2 agenda items that need to be completed after this. So we're really hoping that if at all possible, we can wrap up public comment in about an hour. That way Tricia, who is here, would be able to be here to finalize the vote. So we can hear the public comment, and by 3 o'clock, she can finalize the vote, get out of here, and then we can go to our next 2 agenda items. And then we can end the day. So that's kind of our hope, but I understand that there's a lot of factors going that. So at this point, we're going to break until 2 o'clock. Thank you, guys, and the motion would put up on our screen. I said there was only 2 other items left after this. There's 3. We have not held public comments for items not on the agenda. So that is at the end. So I just wanted to clarify that. Thank you, and Board President.
Thank you. Dolores Trujillo, President. Board Member Allison Cormack.
Cormac here.
Board Member Jovita Dominguez.
Dominguez here.
Board Member David Lawler.
Y'all are here.
Board Member Patricia Nguyen.
When present.
Board Member Neelu Patel.
Patel, present.
And Board Member Vicky Granowitz.
Granowitz present.
Thank you. Quorum has been established. Before we go to open comment, I want to ask the board members one more time if they have any other questions or comments. Board Member Allison Cormack.
I'd like to offer some friendly amendments to the motion just to ensure that we have full clarity. And I think it'd probably behoove us to do that before we open it up. Okay. So first, the suspend word, I understand the intention, suggests to me that we would then potentially reestablish it. So I'm wondering if we could say remove. So this is how I would reword 1, and I'm just going to sort of talk through this and we can see if we get there. Remove the requirement that all participants work in direct patient care before completing the program. And then 2 would be remove the requirement that all participants work passing narcotics before completing the program. So, and then this remainder, I'm not convinced that we need the unless part, because just because we're removing the blanket requirement doesn't mean that the IEC can't require it for someone if it's appropriate. I'm looking for someone on staff to nod that that would be their interpretation. Or not.
My understanding is the intention to put the unless is to make it very clear that the board still has authority to do this, and that it is specifically tied to what was kind of brought out in the report out, which was if there is something that is not commonly done, that it goes through that review process up to the EO level and then back down, so that we can accurately document that there is a requirement that this happened, so it doesn't look arbitrary.
So maybe then this is actually the first thing and we rephrase it, and then the 1 and the 2 are really 2 and 3. And then we'll get to 4. So I think we should just put it in the other way. And I'll let the, perhaps legal can assist us with the part you were just saying in the 3rd. And then in the 4th part, I think request outside of the norm probably isn't clear enough for staff to implement. I think what you were saying that earlier is you said if an IEC recommendation extends length in the program, add an EO review for the case to provide, to verify sufficient information. Because that's what you had said before. So that's one option. Then the other thing that I think we should have here is a timeline. Because, when we're directing you to do something, having a timeline will be helpful. And, I'll look to you to suggest that. So maybe rewording the 3rd section. And then, is it the maker's intention that suspend means we would reintroduce
We
it?
have directed the executive officer to do a review, and that review is ongoing. So I have asked that she report to the EIIC regularly until this review, and then we could reevaluate at that time.
So maybe
that's
we
kind of
should
where
put
I'm
that
coming
in the
from.
motion, that, Okay.
All right, Board Member Vicky Granowitz.
I hear what you're saying. These sound like good ideas. However, we're going to hear public comment. There are going to be other changes to this motion. I think it behooves us, since we've got it on the screen right now, to hold on to the ideas that have come forward. And let's wait until we hear from public comment and then integrate the many changes that are going to happen to this motion instead of doing it now and doing it later.
I think the concern, Board Member Granowitz, is that we may lose the maker of the motion. So if that happens, we'll just deal with that then.
Do a substitute motion.
Yeah.
Any other questions or comments from board members? No? All right, BRN moderator, can you please open this up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Chris Else would like to make a comment. I'm sorry, Chris Elsey would like to make a comment. 1 second, please.
I'm the nurse support group facilitator for the San Luis Obispo area. I would just like to thank the board and especially Loretta for going through all this time to get this all worked out. I'm just a little afraid the motion is too vague. I'm still really against the need for nurses to pass narcotics until they successfully pass the program. I don't understand what successfully passing narcotics means. So to fail that, they either failed it for a patient and they harm a patient, or they start taking it themselves. I don't think either way that is a good way to have a nurse, excuse me, successfully complete the program, whether or not they're tempted or not tempted to take or mess with narcotics. I think that is the main point I would like to make today. I have a nurse that is in her second 6-month period for her IEC meeting, and she's been told again she needs to continue passing narcotics again for another 6 months. So she successfully passed it for 6 months. So now another 6 months, and then her next IEC meeting is right about the time she's going to get out of the program. So does that mean she needs to successfully pass it even longer? So I would just like you all to think about that before we vote on this motion. Before you vote on this motion, be a little bit more specific timelines and exact metrics, because it's still not in the language of their contract that they even need to do this anymore. It's just a recommendation, like it's been said. It's not, I don't understand what a requirement recommendation, if they're told to do it, what is the difference between the two? So thank you very much. I hope this goes the way you guys are all pushing for. I think there's a lot of us group facilitators that are behind you, and we really encourage you to go through with this. Thank you very much.
Thank you for your comment. Yeah, I have Nurse 99. I have her on a phone and I have her on a computer. So I'm going to go for the phone first. Nurse 99. Okay, if you can't unmute from your phone, I'm going to try your computer. There you go.
Can you hear me?
Yes, go ahead. Sorry.
Hi, I've been a participant in the Maximus program since about February of 2022. And first, I would really like to thank Miss Loretta Melby for all of your hard work in looking into this and showing us that you have heard our concerns and our issues with how things have been being run at the Maximus program. Um, One thing I wanted to mention, when you said that you were going to be getting a list of people from Maximus who were affected by this direct patient care and narcotic requirement, my guess was that you meant to see who was extended past their time um, due to that requirement. There's people who have been affected in other ways. It was demanded of me by my case manager this past March that I quit my work from home job. Um, and I was making really good money. I was able to provide for my family and have our health benefits. Since quitting that job, I have not been able to get rehired. So the financial burden has been very stressful to say the least. And I just wanted to know like what, if anything, can be done about that. I mean, some of us have spoken before, wondering, why isn't there employment assistance, to help us find a job that will contract with the Maximus program. Um, and also, you had mentioned celebrating milestones. I would love nothing more than to celebrate successfully completing this program. Um, I'm due to be out in March, and I'm still not quite sure if that's going to happen. But I do thank you for all of your time and effort in looking into this. And like you said, there's a long way to go, but I think that this is a good first step in the right direction. Thank you.
Thank you for your comment. Mac would like to make a comment. 1 second, please.
Um, I have a question slash scenario for the members who are present to consider. What about the medical use of cannabis? For me personally, I had a physician's recommendation for medicinal use of cannabis for over 12 years prior to being placed on probation for a misdemeanor DUI. I was told by my probation monitor that only prescribed drugs would be approved. I requested a reasonable accommodation for medical cannabis due to a chronic and physically painful rare genetic condition, one that is recognized federally as a disability, yet I continue to work as an RN. My request for this accommodation for me to be able to continue safe and responsible use of medical cannabis was repeatedly denied. I was told that my physician's recommendation letter was not a valid prescription, and that without a valid prescription from a physician, if I continued to test positive for cannabis, it would be a violation. That was by my probation monitor. There was no possibility of obtaining a prescription for cannabis, which I explained in detail to my probation monitor, since physicians do not prescribe cannabis, as federal law specifically prohibits doing so. Instead, doctors in California recommend cannabis for appropriate medical conditions. The BRN would not budge from their position. My probation monitor would not consider my accommodation, even though I have a well-documented chronic disability. My probation monitor went as far as to suggest that I seek out prescription opiates, which I chose not to do. Since the start of my probation, I've been forced to live with physically debilitating pain. I am deprived of sleep because of it, but I continue because I want to successfully complete my probation. So I just want to beg the BRN to consider compassionate use of cannabis as a safe alternative for nurses in these programs, especially when they have a long history of responsible use of medicinal cannabis. And since the state has approved compassionate use of this plant since 1996. Thank you all.
Thank you for your comment. Maria would like to make a comment. 1 second, please.
afternoon. I would like to thank the BRN for trying to do what they can to assist us. My question is there a limit to how long our program can be extended? I have been in the program, it's gonna be over 6 years by the time I have my next IEC meeting. And there was no explanation given to me as to why I keep asking. I still don't know why. I had to go out of my way and spend $700 to get a second psych eval, even though the first one cleared me to go back to work, and yet they still decline me. And I truly believe that they should have a limit as to, okay, like 6 years, it's a little bit going overboard. I have been sober for the past 4.5 years. I have been very consistent with my program since then. I talk to people that are barely 3 years in, and they look very positive that they're going to be finishing soon. And there are people like us that are, we're just being retained for no reason, and our program keeps getting extended. I have written a letter to one of the BRN members, and I received no response. I have submitted a letter of appeal to Maximus, and I received no reply. The only thing they said is that I still have to wait 3 more months for my next meeting. So I think there is something that needs to be said to where how long, I mean, like, am I gonna be in the program for 10 years? Over 6 years, it's a little bit overboard, and that needs to be cleared out. Thank you.
Thank you for your comment. AT would like to make a comment. 1 second, please.
Can you hear me?
Yes, go ahead.
Okay. I enrolled in NIP in October of last year, just short of a year after getting a DUI. And from the time of my arrest, I've taken full responsibility for my actions. I've remained abstinent from alcohol and have been completely committed to my recovery. And in July, I was seen by my IEC to request to return to work after 9 months of being out of practice and 20 months of sobriety and recovery. And I've demonstrated compliance with everything and more than what was required of me in my NIP. And I was found safe to return to work in 2 clinical assessments from psychologists, one who was appointed by Maximus, as well as my personal psychologist. My request was not only denied, but my IEC said they will not see me again for 6 more months. And the feedback I received was that I moved through my recovery too quickly. They questioned whether I actually completed the 12 steps as I said I had done, and they speculated that I was not far along enough in my recovery to take on a sponsee. They recommend I rework the 12 steps. Now, I feel this decision is punitive and was made with prejudice. And I understand that there's a lot to consider public safety, and it's their utmost duty to aid the public. But I actually plan on working the 12 steps again. AA is a lifelong endeavor, but I would argue that I've taken my time with them. And anyone who's completed them is expected to take on a sponsee. They didn't check any of my character references. 6 people wrote letters, including my sponsor. And so they say that my claims are untrue, and that's all the feedback that I received. So I just wanted, I would hope that they would use clinical psychologist opinions in their decision for allowing people to return to work, as opposed to what seems like biased, subjective information. Thank you.
Thank you for your comment. Jessica would like to make a comment. 1 second, please. Jessica, I have you on a cell phone and a computer, so I'm going to try a computer.
Oh.
Yep, go ahead. You're there.
Oh, you can hear me? Okay. So, hi, my name is Jessica. I'm a participant in the program. To the entire board, especially Allison Cormack, David Lawler, and Trisha Wayne, I am so grateful for your support and thoughtful questions. It's clear that you understand the serious problems with this mandate. Ms. Melby, I appreciate your insight into just culture, and I see your deep understanding of this issue. My concern is that the IECs and case managers do not have the same level of education and understanding as those on the board today. I appreciate the motion to suspend this mandate, or better yet, to remove it. I'm surprised this wasn't done sooner while fact finding was occurring, but I'm grateful for some movement in the right direction now. I want to speak on the record to say implementation of this mandate would be unethical and unfounded as supported by the addiction medicine experts. If it is approved anyway, which is just mind blowing, we as participants and case managers need to understand the meaning of case by case. As a participant, I can attest that so far every instance of case by case measure has been a blind mandate affecting everyone. I have never before seen thoughtful consideration by a case manager or IEC, so how can we believe that we will see this now? How will the decision makers be trained to identify those who need to pass narcotics and work in patient care before completion? How will you even determine the criteria that needs to be met since addiction medicine experts themselves agree that this is not in alignment with current addiction treatment methods? And when will we have knowledge of the requirements that have been made up? Because I don't think it's okay anymore to just tell us something is case by case and leave it at that. Not when we have been lied to countless times to believe something is case by case only to find out that it's not. Please remember that the nurses who want to work in patient care are already doing so. The rest of us are in jobs that we love and have no desire to work with patients again. What a dream as a nurse to never have to wipe a butt again. We are happy. We aren't unstable addicts lying in wait, just waiting to get out so we can use again. Please remove this prejudice from the minds it occupies. And thank you again for your time.
Thank you for your comment. Gabrielle Anderson would like to make a comment. 1 second, please.
Can you hear me?
Yes, ma'am. Go ahead.
Thank you very much. At the risk of repeating what's already been stated, Lori and the rest of your team, I cannot thank you enough for your to these ongoing issues with the program and possibly Maximus specifically. I am a former participant. I ended up withdrawing from the program because of these indiscriminate applications of the recommendations and misinterpretation, like you said, of the suggestions that are placed in the rules that you all go by. When you said just culture, I was brought to tears because I think that that's absolutely what is lacking in the current application of the IEC committee meetings. I am profoundly, I said, I jumped in joy and yelled in my apartment by myself, yes, 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 when you said that they will be required to have bias training. And I would also respectfully request that along with that is trauma informed reaction with participants. We've all been through a lot. I know my time's running out, so I just also wanted to touch on the gentleman who said that he would expect that the IEC members are using common sense. And again, respectfully, I don't think we would be here in this position if that was happening. It's been well stated that these rules and suggestions have been applied as a blanket interpretation to all participants with no recognition of our individual circumstances and what brought us there. My contract did not state that it was a 3 to 5 year program or that I would be required to do patient care or pass narcotics. I could not find jobs that fit those requirements, and so I subsequently left the program. If we violated our contracts, we would be in major violation and have our program extended. But we feel that our contracts were changed without our consent. And quite frankly, I would never would have entered this program had I known what the requirements would be changed to further in my program. Additionally, there are nurses there were nurses in my nurse support group who adamantly did not want to return to patient care. It would absolutely trigger a relapse for them using narcotics, and to force them to do so is not only inhumane, but suggests the profound lack of understanding of recovery that has been presented through this Maximus intervention program. Thank you so much for your time, and God bless you all for the humanistic work that you're now doing.
Thank you for your comment. George Olson IV would like to make a comment. 1 second, please.
As a nurse for 16 years, specializing in pediatrics, critical care, and leadership. And nursing is not just a profession, it's a passion, and it's obviously reflected in my commitment to continued education, including obtaining my CCRN and CNML certifications, and the pursuit of my MSN, which I'm one class and one practicum away from. Last December, I was enrolled in the probation program, and unfortunately, this led to a loss of my job that I cherished for 13 years and required me to pause my MSN studies. This period has been obviously very challenging, but to add on top of that, I had the birth of my son in January. But despite these challenges, I remained dedicated in meeting the program's requirements and working towards an early termination. One pressing concern I want to address today is the restriction on international travel due to drug testing requirements to the third-party Vault Workforce app. This restriction has deeply impacted me as half my family resides in Argentina, and they haven't been able to meet our son. And additionally, my cousin, she qualified to compete in the women's wrestling in the Olympics in Paris. And while I understand these events are considered personal leisure, I have not sought exceptions, but it does raise one important concern about emergency travel. Excuse me, I'm just getting emotional because I don't want to revisit this and I don't want this to happen, but in the unfortunate event of a family emergency, such as a funeral or a serious health issue, am I allowed to travel to Argentina? And I just ask for clarification from this matter to avoid any added stress during such a critical time. And again, thank you for taking the comments and greatly appreciate it.
Thank you for your comment. Chris would like to make a comment. 1 second, please. Oh, I have two Chris's, so I'm going to try Chris on the computer. Oh, I'm sorry. Yep, Chris, capital Chris on the computer.
My name's Christine, and I am actually a second-time a participant in this program. I relapsed on opioids again last year, or a little bit over a year ago. And this was after a successful completion of my program the first time around. I went back to practice at the bedside as an ICU nurse giving opiates. And I did that flawlessly for 18 months. I was discharged out of the program and I unfortunately relapsed, which I found myself back in. I'm very grateful for the second chance. But I do want to say that now, in hindsight being what it is, my career path does not, moving forward in my career path, I do not want to be at the bedside anymore. It would be detrimental to my career, my sobriety, which is number one most important thing for me. And I know that we've talked about case by case, but again, I think we've said, sometimes case by case doesn't really go that way in this program that well. So I just wanted the board to hear my story and to know that I'm not the only one out there. That yes, I was diverting. Yes, I'm an opioid addict, but no, my career does no longer, my career path no longer is at the bedside. And I think that, knowing what I know now, the first time around, if I had carved out a new career path, say in case management, I'm teaching now, which I love, maybe this relapse wouldn't have happened this last time. So thank you. And thank you, Ms. Melby, for all of your hard work in starting to get some clarity. It's the most clarity I've had and it's been over 6 years that I've been participating in this program. Thank you.
Thank you for your comment. Committee Chair Nguyen, there are no other public requests for comments on the WebEx. Do we have any public requests for comments on the, I'm sorry, at DCA HQ?
No, there are no public comments here.
Thank you. Would you like me to close this window?
Yes, please.
I do have one comment that I do need to respond to, and that was the travel one. There is no travel restrictions, and so we will make sure to make that very, very clear. What he had mentioned was the testing availability when you were traveling. Now that we have the options for the saliva testing, that is a kit that can be sent out to them that they can take with them. They would still be required to do all of the requirements where they call in daily. If it is their turn to test, they could then do that saliva test. And then on return, there are options that are like hair or nails that do a longer detection rate, and that would be an option that we could utilize at that point to do a return test. We have heard that there are times when people shave and don't have hair and aren't able to do that, but we could still collect at that point. So there is not a travel restriction. I want to make sure that that is clear. International travel is not a restriction. It was a concern with testing, and we have the ability to work with testing. And so we will continue to work with Maximus. We'll continue to work with our board staff and IEC to ensure that that message is sent.
Thank you very much, Ms. Melby. I would like to thank very much Board Member Cormack for friendly amendments, and I would like to turn it over. Well, Harry?
Yeah,
Yeah, please.
I have a comment on the change in the wording, okay? The implications from suspension to removal go far beyond just the simple word. And I believe the suspension use is appropriate because in this case, it also reaffirms the authority of the board under law to take the action that they took initially. And to say otherwise would have other implications. So I would ask that respectfully ask that the board member rescind the request for the change in nomenclature for that reason.
Super helpful. Would the chair allow me to just reword this, keeping the suspend to try to address clarity a bit? Okay, so I'm trying to incorporate the unless part into the 1 and 2. So perhaps 1 would read, suspend imposition of requirement that participants work in direct patient care, comma, unless there is evidence of patient safety concerns. And then we just replicate that in 2. Suspend imposition of requirement that participants work passing narcotics, comma, unless there is evidence of patient safety concerns. And then the 3rd bullet would be, if an IEC recommendation extends length in program beyond 3 years, comma, EO review is required to evaluate evidence.
I'm comfortable with that. I never for a minute thought I had the amendment perfect.
The collective work, yeah. I
Felt
think
we had to start somewhere, and I do think that your wording has a little more finesse.
everyone should, it's just a draft. I think the only thing that's not incorporated in that wording is, again, the time frame for when we expect this to be completed. And I defer to staff and yourself as to what's appropriate, but that's a suggestion of how to make sure that the board's authority remains and the blanket requirements are removed.
I have some suggestions here. In any cases in which either or both of those requirements were the only requirements preventing a participant from successfully completing the program, and where those requirements are removed pursuant to this motion, direct board executive management to work with the IP program manager to have cases presented to an IEC as soon as practicable to consider for consideration of program completion. And then the other one that I think was incorporated in that was direct board executive management to provide an update to EIIC at the October meeting and going forward regarding cases in which these requirements were removed or imposed pursuant to this motion. I think those were the other 2
I
suggestions.
would accept both of those as friendly amendments if my second holds. And then I would just ask council, can we do all of those three things in one motion?
You've incorporated them all?
Yeah.
I don't see why not.
Okay.
Yeah.
Any questions or comments? Go ahead, Ms. Granowitz.
I don't know that we can do it today, but I do think there is some validity to trying to define what successfully passing narcotics means. And is there a limit to how long someone can be kept in the program? That if someone is extended, there needs to be written explanation for why that's to be done. And that there's a definition of what case by case means.
So there is a definition in California law that discusses case by case. So that one's done. The extension in the program for EO review, that is incorporated in this and some of the direction that was already done. As for the extending, how long that can happen, it is required 3 years continuous sobriety. My assumption, and only an assumption, is that a sobriety date may have been changed based on a major or a minor violation. We can look into that and see what occurred. But it is based on 3 years continuous sobriety, and that is the law. And so I think we would have to find out what that is and see what occurred with this case specifically. Right now it is put forward as a 3 to 5 year. So to have a 6 year, that's kind of a little abnormal. That would be a case that would come in front of the EO going forward.
Okay.
Right. So that would have that review. And then I know there was one more, Vicky, that you brought up on there. I wanted to make sure I caught that.
What was your first one? What does successfully pass?
There, that's the
narcotics
one.
mean?
Yes. That, we would have to define that specifically in regulations if we were going to move forward with that. But what I would look at this for today is no relapse.
Okay.
Because that's what then affects moving forward. If you get a patient harm incident, that is an additional complaint that comes forward outside of the program, and it goes through a separate process. And so if there was patient harm, that would be handled separately. And so that is something different. So this would be specifically to the intervention participants course through this, and it would be what you would not want to see happen, which would be a relapse. And so I think we can be very clear that says today how we implement it, which would be supported, would be if this requirement is imposed where it's direct patient care with narcotic passing, that safely passing would mean no no diversion, no relapse.
And
Is
then
there a time? Oh, sorry.
Oh, I'm sorry. I just wanted to mention medical use of cannabis.
Yes,
It's very complicated.
it is.
Because I've had doctors recommend cannabis for me for the treatment of my
Yeah.
condition. They won't write a prescription. And even though they know that the medical research shows that it actually works for the control of symptoms in patients with multiple sclerosis. And if you're taking one medication, they don't want you taking the cannabis at the same time. And even though you're not necessarily taking them on the same day, they show up in your blood work, and then they'll remove you from other medications. So my heart goes out to the woman that called, but I don't think there's anything we can do about that. I can't do anything for myself about it.
Yeah, that is a loaded topic. We do have a precedential decision on our website that we put forward that says nurses can pass cannabis to students in school. So we are supportive of that treatment regimen. We also know that it is federally prohibited and prescriptions are a federal issue. And I believe that person that was speaking was talking about her probation, not
probation.
intervention.
And so we would have to look at that separately as well. I know that currently our practice is we do not discipline nurses that utilize medical marijuana or utilize marijuana recreationally, with the caveat is they cannot be under the influence while at work, right? And so that's kind of the issue. So I know that we are fairly up to date with the use of cannabis, the cannabis as a treatment. I could look into some of those other ones to see where we're at, but there is not a straightforward, clear message for that one yet, but we'll work towards that.
I just have one question, Lori. When you say past narcotics with no relapse, is there a time frame on that?
So the time frame of what we would describe a relapse, or the time frame as what we would require for passing of narcotics?
Or
Like for
passing of
6 months,
narcotics
1
with
year?
no relapse?
So what that happens is that decision would have to come from the IEC committee. And as we kind of talked about today, is they would review maybe like the CV, the resume, what brought them in, what their path is. And if that was determined, what we have been doing when we look at this is worksite monitor and looking at, 6 months, 12 months, stuff like that. I think honestly, there's not a specific time frame that can be put forward because we are looking at this on a case by case. But my understanding and my hope is if it is demonstrated that it could be done for 6 months, my assumption is you wouldn't have to extend it to a year, right? Unless, and to my comment with that is what would trigger them to extend it longer would not be work related, right? Because if your worksite monitor reports are coming back fine, if you're working and you've been passing for 6 months and everything is fine, there's no diversion, there's no nothing. My only thought would be is if they extended it for another year, it would be based on something else that is highlighting them that this is an issue. My hope is that they would just say, continue to work in this role while you address such and such, because there has not been patient harm, right? Or patient safety issue. And that's what is stated specifically in this motion is unless there is a risk for patient safety. But if a person has been passing successfully for 6 months where there's no relapse and there's no diversion, then there is no evidence of patient safety at that point. So I cannot see how that would be able to be continued as a request. They could continue in that role, but it would not be something that would be a request. What that would highlight to me is that there's another issue that would need to be addressed, and we're not addressing that issue through direct patient care. We need to actually focus on the issue that's causing that to be brought forward.
Thank you.
Thank you. Thank you very much. Just to be really clear, I'm going to ask Board Member Cormack to state the first half of the motion again, and then I will ask EO Melby to state the second part of the motion so that everybody is clear, and then we'll take a vote. So thank you very much, Board Member Cormack.
He's put it on the screen.
Okay.
You're the best.
While staff is working on that, shall I read? Okay. So item 1 would be suspend the imposition of requirement that participants work in direct patient care, comma, unless there is evidence of patient safety concerns. Item 2 would be suspend imposition of requirement that participants work passing narcotics, comma, unless there is evidence of patient safety concerns. Item 3 would be if an IEC recommendation extends length in program beyond 3 years, EO review is required to evaluate evidence. And then I hand it over to Executive Officer Melby for the EIIC updates and something else.
So number 4, or this one here, it's up here. Great. So I'm going to read from there. In any cases in which either and or both of those requirements were the only requirements preventing a participant from successfully completing the program, and where those requirements are removed pursuant to this motion, direct board executive management to work with IP program manager to have such cases presented to an IEC as soon as practicable for consideration of program completion. And then direct board executive management to provide an update to the EIIC at the October meeting and going forward regarding cases in which these requirements were removed or imposed pursuant to this motion.
Wow.
Thank you all very much. Board Member Lawler? No, no. Okay, so.
So
okay,
moved.
Great.
So moved.
We have a
That's a
motion
first.
and a second.
Yep.
We're going to go to a vote. We don't
Roll
need to
call.
do more public. So we're going to do a roll call. Board Member Cormac,
Cormac, aye.
Board Member Dominguez,
Dominguez, yes.
Board Member Lawler,
Lawler, yes.
Board Member Trujillo, Board President Trujillo,
Dolores, yes.
Board Member Wind, yes. Vice President Patel,
Patel, yes.
Board Member Granowitz.
Granowitz, yes.
Okay, that motion passes.
Shannon, will you please come to the front and report out for 4.2 and 4.3, please? You have a 15-minute time frame? No, I'm joking.
Well, this is information. This
Do
is
it in
information-
5.
This is information only, so thank you. Welcome, Shannon. Yeah.
Oh, Lord. Do you need mine? Okay.
Hi, thank you.
Sure. Mike. There you go.
There we go. Shannon Johnson, Enforcement Division Chief, and I'm going to present 4.2, which is the overview of, thank you, Matt, the overview of the, yeah, of enforcement, intervention, and investigations. So I'm not going to read through all of this. I'll just ask if you have any questions at all. But one point I do want to make on the stats. Time was not on our side, and I really wanted to provide you the fiscal year-end stats in comparison with the past previous fiscal years. We weren't able to get that to you, so I'm going to get that for the next board meeting so you can see the last few fiscal years in comparison. So Table A is basically just fiscal year 23-24 numbers. And then, of course, we're still trying to recruit expert witnesses. So the information is in there, as well as for our IECs. As you know, we have 3 nurse members, 1 physician member, and a public member for each IEC. We currently have 9 IECs across the state. Currently, we only have a few vacancies, which in 4.3, I'm going to ask for, sorry, and I want to look over here too. So I'm going to ask for the board to vote on whether or not to accept the appointments and reappointments that are listed in 4.3 later. So with that, are there any questions on 4.2?
Yeah, I just have a question. Were there any numbers here? You know, you have such a better context than we do. We look at these, you know, from time to time, but were there any numbers here that kind of kept you awake at night or made you nervous of, you know, that, wow, we're really kind of slowing down here, cases are at the AGs too long, or do you feel like we're in good shape?
No, I think we're pretty on track. I mean, as far as consistency throughout the last years, if you look back, I think, you know, COVID, of course, you know, it was a you know, huge change throughout the board, across the board. However, enforcement, we've gotten really efficient with our cases. We've been able to go paperless. We've been able to move cases faster because we're not relying on, you know, USPS. We're not relying on GSO or some sort of service to, and we're not printing out all of those documents. We're using cloud links now to send things out, you know, but they're secure. But we're using that to send to our experts for review. We're using those links to send to the AG's office for those cases that need to go there. And that's how we're retrieving everything back as well. So we're able to move things a lot quicker than we were. There are some things that have come up, for instance, and it won't happen in this, but we've recently had a case that had went viral on the internet. So of course we got about 1,000 complaints on one person. So that does skew our numbers a little bit when things like that happen. And that just recently happened over the past few months. So we have things like that. Other than that, I think we've pretty much been status quo in enforcement. And of course, always looking for other ways to improve and, you know, make any process more efficient, because 10 minutes across, you know, 1,000
Yeah.
cases a month really adds up.
Yeah.
Yeah.
Thank you. Thanks very much.
You're
Any
welcome.
questions? Yeah, please go ahead, Board Member Cormac.
Thank you, Chair Wynne. Ms. Johnson, I'm seeing under intervention, we've been talking a lot about, 2,770 RNs referred. Seems like a big number.
That is from the inception of the program. That is
Okay.
not just the current fiscal year. Just to be clear, we have not had
Okay.
that many in a fiscal year, ever.
Yeah, okay. It does have fiscal year at the top, so that was, that seemed, out of it. Yeah, I'll just confirm that it does seem, and, on the probation side, on the discipline side, it does seem like we're getting, the things we're reviewing have more recent incident dates.
Yes.
So I can confirm that I see that process speeding up, which is only to everyone's benefit, particularly the public. So I have noted that.
Yeah, the ones that you will see with later dates will be a lot of your insurance claims, the 801 reports that we get that are mandated reported to the board. A lot of times we don't get those until the facilities have completed their investigation and then it goes through the insurance claims, then we get it. So sometimes it's 3 or 4 years later. So I just want to make sure you're aware. You're still probably going to see some of those. Yeah.
Great, thank you. And Board Member Patel has a question.
Thank you. I see here under probation that probation monitors each have an average of 44 active cases. I see also that you're recruiting for probation monitors and there's vacancies. 44 seems like a rather large number. I imagine you want to decrease that. What would be an ideal goal in your mind, or just what are we looking for here? Had you asked me that about 7 years ago, I probably would have said we need to decrease because we were at about 140, 150 cases per monitor. So we've actually, with hires back about 6 years ago, 7 years ago, we were able to hire additional probation monitors. We now have approximately 15. I believe right now we only have 1 vacancy. So we were able to kind of spread those out more. So they're at a more, I used to say about 50 cases per. It also depends on the type of monitor. For our higher level monitors, they have mostly chemical dependency cases because there's a lot of intricacies with that, just like monitoring an intervention program participant, all of the testing, the mental health, the physical exams, all of that. So they have could possibly have a lower caseload, but they have more work with those caseloads. And then our lower level analyst, and excuse me, you're not low level. I just want to make sure I make that clear. You're very much appreciated. But our staff services analysts, they do more of the practice cases where we're really only monitoring conditions 1 through 13, all of the employment, the education, that piece, and it doesn't have all of the optional conditions of 14 through 20. You're welcome.
Thank you very much. Before we go to public comment, is there any other question or comment from the board? Yeah, go ahead, Ms. Granowitz.
I'm not sure this is the appropriate time, so tell me if I'm wrong. But in doing the Breeze reviews, we see a lot of DUIs, and it seems to me that they could be standardized and not necessarily come to us at all because they pretty much fall into a couple categories. And so it just seems like we're spending a lot of time on like the wet ones, and they're always resolved in the same way, like 90% of the time. So is there any way to streamline that?
There's a couple things we've done. So one of the items, the ones that you see are the more egregious cases. There was more underlying conduct during or surrounding the time of arrest. For instance, children in the car, high-speed chase, narcotics found, things like that. When we have a low-level DUI, first-time criminal offense, no other egregious circumstances, a lot of those could go to a citation. So they get more of a citation notification if we have a second offense or we have anything egregious around that circumstance, they would then possibly come to you.
Another thing we did some years ago is we worked with the Attorney General's office. We call our paper cases fast track cases. So they're basically either the out-of-state disciplines where we get just the paper notification of the disciplinary action from the other state, or we get the arrest notification and the court documents. Those we move very quickly. I don't know if you've noticed the dates on those is usually within 3 or 4 months. We have a pleading, a decision, boom, it's to you for vote. And so we've really streamlined that process. And as you can see also over the years, previously, our criminal cases were higher than our public complaints. We have now flipped that. Our criminal cases are now under, I believe it's under 30%. Under, and it used to be 50, 60%. So that's changed as well. So they've come down quite a bit. I don't know why our criminal cases have been less. I would just like to think that nurses aren't drinking and driving as much.
Let's all hold that thought. Great. So board moderator, would you please open us up to public comment?
We will be opening for public comment. Please refer to the screen share for members of the public to see how they should type in their request for comment. I have activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public. Type in, "I would like to make a comment." Jessica would like to make a comment. 1 second, please. Jessica, go ahead.
Can you hear me?
Yes,
Can you
go
hear me?
ahead.
Okay. Sorry, I was still typing it out. I was going to ask if I can make a comment about the illusion of choice when it comes to the substance use disorder treatment groups that were provided, just because I didn't get a chance to last time. But I understand if it's not appropriate.
Yeah, I mean, we're not supposed to at this. We have moved on to the next agenda item. If it's something that you think is imperative for me to know or whatever, you can go ahead and email me. My email is loretta.melby@dca.ca.gov.
At dca.ca.gov?
Yes, and if you go into our website, there's an rn.ca.gov, which is our website. The bottom right-hand corner, it says contact us, and then there's a link to executive leadership,
Oh.
and my email is in there as well, if you didn't have a chance to write it down.
Right. All right. Thank you, Ms. Melby.
Thank you.
Okay, I'm gonna try the other Jessica just because she typed in there. But hold on, let's see if this is the same Jessica.
But thank you for unmuting me. My name is Jessica. I am a nurse practitioner and I am on probation right now because I got a DUI. I had no other extenuating circumstances. This was my first offense. I've never had any issues with my license, my driving license, or my professional license. And so I just thought it was interesting that you said, some people get away on a citation. I'm not saying like, I shouldn't be held to a certain standard as far as answering to my DUI, but, again, I'm on probation now. It was an extremely like stressful time. I don't think that, relapse would be in my future. Like it's not going to happen. But outside of that, it's just interesting that I'm still on probation. I lost one of my jobs due to this whole experience. And then I have to sit here and pay for all these random testing. I'm not opposed to it because I'm, not worried about like testing positive for anything, but it's more of a financial issue. So that was just one comment I wanted to make, that I was never offered like citation. The BRN sent me a really long letter threatening to take my license away. I felt like it was just like a death threat almost, like it was just really scary. And it was just never offered like, oh, you have this potential to just, kind of have a citation. It was like, your license is going to be taken away. So that was just one thing I wanted to comment on. I didn't appreciate it. And then a second thing, as far as like the international travel or just traveling in general, as far as like my probation monitor goes, I mean, like I kind of had asked her about it. And it didn't seem like she was aware. It was pretty much like, no, you can't do any international travel. Saliva was never like an option. I've heard about it in my nurse group, but outside of that, it's never been an option that's been brought up. So that's also something like I would like to put out there. Like, I don't know where this whole saliva thing even came from. Because I've never heard of it ever being an option.
Okay. We hear you, thank you. And there is a difference between probation and intervention. It is based on contract and stuff right now, but we are working on that as well. So thank you.
Thank you for your comment. DJH would like to make a comment. 1 second, please.
So as we're pulling up the next ones, I just wanted to make sure that people understand that we're doing comments on the information only presentation that was put in front of us on the enforcement intervention kind of investigation activities, the specific report out that's in our materials. If this is additional comments related to the prior agenda item and stuff, I ask that you hold it for public comment for items on the agenda, not on the agenda that are coming up. We have one more agenda item after this. So if this is not specifically related to the report out, I'm going to ask you to hold it till that time period.
DJH, go ahead.
Well, after that, I will, I just I had a clarifying question on the wording of the last agenda item since we didn't get to comment after the wording was changed, but I can hold that until the end if that would be more appropriate.
Appreciate that. Thank you.
Thank you. Participanto would like to make a comment. 1 second, please.
Just wanting to get some clarification on what would be considered like for the participants that have worked in non-patient care such as telehealth, nursing, and they've been in the program for 4 years, let's say. What would be considered public safety issue? Is that mean preceding the program, or because if you get in the program due to diversion of narcotics, does that mean you're a public risk and this can't apply to you?
Nothing is across the board. And then again, this is the comment that you're doing right now is from the prior agenda item. So I'm going to ask you to hold that. In any of these specific kind of case by case items, I'm going to ask you to reach out to your case manager at Maximus and we will work with them to work through those kind of items so we can get responses back to you guys.
Okay, thank you.
Thank you.
Thank you for your comment. Maria would like to make a comment. 1 second, please.
Hi, yes. I just would like to ask the question about, I know this is probably has nothing to do with what we're talking about right now, but I know that in a previous meeting, it was said that if the program required a second psych eval, that we would be reimbursed for that. And
So-
I don't know what
so-
happened to that.
Okay, ma'am, again, this is public comment for item that was already discussed. You can, if you choose to, do this in public comment for items not on the agenda at the end of this agenda. But honestly, those kind of questions really should go back to your case manager at Maximus, and then we will work with them to get those answered for you because these will be individual basis. There's a lot of information that needs to be looked at and received to see what we can do to help with you, and that can't be done in this kind of open forum, especially with the purpose of maintaining your guys' confidentiality.
Okay, thank you.
Thank you for your comment. Anonymous would like to make a comment. 1 second, please. Oh, I have 2 anonymouses. In the future, I have no idea how we'll be able to differentiate between people with same names. So I'm going to go with the first one, and we'll even give the second anonymous a chance to speak. So 1 second here. Anonymous, go ahead.
Can you hear me?
Yes.
Okay. I'm wondering why, if we're on probation, we can't have it removed from our license after we complete probation. For-
Ma'am, I'm going to interrupt again. This is agenda item 4.2, and it is specifically on the report out from the the enforcement committee. So these are comments that we cannot legally hear at this point because it's not related to the specific agenda item. If you have questions, it sounds like maybe probation, reach out to your probation monitor, and they will work with us to get you appropriate response back.
Thank you for your comment. I'm going to go with the second anonymous just to be safe. Anonymous on the cell phone, if you wish to make a comment. Okay. Board EO Melby, there are no other public requests for comments on the WebEx. Do we have any public requests for comments there at DCA HQ?
No, we do not. And thank you for diverting to me, as board member Patricia Nguyen did have to leave. So thank you for that. You can go ahead and close the window.
Thank you.
Okay, that was information only, so we will move on to the next agenda item, and that is 4.3, discussion and possible action, appointment of Intervention Evaluation Committee, IEC members.
Pursuant to 2770.2 Business and Professions Code, the board is responsible for appointing persons to the Intervention Evaluation Committee. Today, I have 5. One of them is a reappointment. It is Richard Avia, one of our RN members in IEC 4 for reappointment, and his term expiration would be, excuse me, I need my glasses, 6/30/2028. The other 4 I have are new appointments. It's Elizabeth Haviland, an RN member, IEC 5, Joan Taylor, RN member, IEC 7, Stephanie Evangelista, RN member, IEC 10, and Elizabeth Barrera, physician member in IEC 10. All of these are new appointments, and the term expiration would be August 22nd, 2028, if approved.
Thank you, Shannon. Any questions or comments from board members? Okay, I would like to make the motion to accept appointment of Intervention Evaluation Committee members that have
Cormac,
been,
sorry. Go ahead.
that were listed.
Cormac, second.
All right, thank you. BRN moderator, can you please open it up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Do we have any public requests for comments at DCA HQ?
We don't, it doesn't appear we have any requests for comments here at HQ.
Thank you. Would you like me to close this window?
Yes, thank you. All right, we'll take a vote on the motion. Board Member Allison Cormac,
Cormac, yes.
Member Jovita Dominguez,
Dominguez, yes.
Board Member David Lawler,
Lawler, yes.
Board Member Neelu Patel, Oh, yeah. And Board Member Vicky Granowitz.
Granowitz, yes.
Thank you. At this time, we're at item 3.0. This is public comment for items not on the agenda, items for future agenda. BRN moderator, can you please open it up for public comment? And one thing I need to mention also, public comments will be limited to 2 minutes or less per comment. Thank you.
I'm going to tag team onto that as you set that up. And we do still maintain a hard stop at 5 o'clock.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." If I have requests from people with the same name, I will announce that I'm going to announce computer and telephone. So please be.
That's great. Thank you, Mark. You've been doing a great job. The one thing I just want to reiterate is one time only public comment, please. So we're not
Correct.
having repeat public comments from the same person.
Yes, one time only, 2 minutes. You only have to request once. I will get to you. Just my listing is not the same as what you think you submitted, so I will get to you. Jeffrey R. Darna would like to make a comment. 1 second, please.
Can the board hear me?
Yes, go ahead, sir.
Thank you so much. Good afternoon. My name is Dr. Jeffrey Darna, and I serve as the program director for the University of Southern California Program of Nurse Anesthesia. My comments are in relation to some discussion that occurred yesterday and last week. A little briefly, our program is a full-time 36-month, approximately 64-hour per week doctoral curriculum that educates experienced critical care nurses to become full-service nurse anesthesiologists following program completion and passage of the National Board certification. It's important to recall that only one standard exists in anesthesiology. Our nurse anesthesia residents, graduates, CRNA colleagues cannot and do not provide a lesser anesthetic compared to other anesthesia professionals. In other words, we don't put patients to sleep 50% of the way, and anesthesiologists or physicians come through and do it 100% of the way. Because of that single standard, the core training in anesthesiology is remarkably similar, regardless of the individual's primary healthcare professional licensure. CRNAs are educated to provide care across the perioperative continuum for all patient populations and in every clinical setting requiring expert anesthesia care and consultation. As a CRNA educator, I am concerned about the California Department of Public Health surveys in the Central Valley hospitals earlier this year. In addition to that, in addition to the more than 1,000 surgical case cancellations, the CDPH surveys have resulted in misinformation about nurse anesthesia practice, education, and the impact on healthcare here in California. That misinformation is affecting the training of our nurse anesthesia residents, where we are facing purposeful restrictions on education and training, particularly at some very large county-run healthcare facilities. I understand how CDPH surveys are triggered and their critical importance, but a BRN must support the public needs by supporting CRNAs and their ability to practice independently without physician supervision. I respectfully request the BRN communicate to CDPH, CMS, all hospitals and surgical centers in California about the CRNA scope of practice and standards to ensure the situation never recurs. And finally, Any BRN member wanting to learn more about our nurse anesthesiology educational program at the University of Southern California should contact me directly. I'm happy to show you the depth, complexity of our curriculum and explain how our structured approach produces full-service, independent nurse anesthesiology professionals. Thank you for allowing me to share this comment.
Thank you for your comment. BJH would like to make a comment. 1 second, please.
Okay, can you hear me?
Yes, ma'am. Go ahead.
Thank you. First of all, I did want to say to Miss Melby and any of the board staff involved, how grateful I am for the deep dive you've done and all of this over the past several months. You have no idea what it means to us as participants to feel that we are being heard and you are looking at all of these things so intently. And I will ask my case manager about this. And I know you keep repeating case by case, things are case by case, but unfortunately as participants, we have very little faith in case by case differentiation, as we have seen time and time again, requirements being blanketed. So I am asking if you can just give an explanation or even better yet, examples of what additional evidence of patient safety issues means. We don't know what that means in the wording of that agenda item. Also, you had brought up the nurse support group and the fact that the nurse support group facilitators can decide what they want to charge, which is fine. But when we enter the program, we are not given any of that information. We are told this is the one in your area, so this is the one you need to attend. Can we possibly talk about providing that to participants when they enter, since all of the nurse support groups are remote? Here's the list of them. This is what they charge. That way you can make a better formed decision, and financially, you know what you are going to be responsible for and what you can afford. And then also, I'm very encouraged by all the talk of just culture, and IEC is starting to receive additional education and training. But what about those of us who have been affected by some of the decisions that have been made? While we're waiting for that education to happen, I just had my IEC and just received a new contract, and I'm being required to attend 2 of my 4 NA meetings in person. I have no minor or major infractions. I have, a model participant, so far, almost 2 years in. I don't know why it's being required of me. And it's certainly a hardship. I work full time. I have 3 kids. I'm having to leave work early and use PTO to drive to an in-person meeting. So it's actually costing me money to attend a free NA meeting on a weekly basis in person, because now I'm required to do 2. So what are we supposed to do in the meantime while all this education and training is happening? What about the nurses who were removed from work for 30 days for missed check-ins? What is being done for them? They lost a lot of money. I'm just wondering if there's any reparations. Just culture, if a patient's giving a med in error, they're not responsible for paying for that med. So I just am wondering if anything is being looked into for that, and what your advice is to us in the meantime while we're waiting for just culture to happen, but we are still having to pay for and with our time and money for these requirements that have been imposed upon us. Thank you.
Thank you for your comment. Anonymous on the computer. 1 second, please.
Okay, can you hear me?
Yes, ma'am. Go ahead.
Sorry for misspeaking at the wrong time earlier. I want to ask the board why, or if we can revisit, maybe allowing probation nurses to request to have an accusation removed from their license after we complete, which for me is 3 years. I did not have the option to join the Maximus program, as I couldn't afford, even with disability from the government, to be off of work for up to a year, like some Maximus participants have been. I have no other source of income, no family or spouse to rely on for financial support or living arrangements if I can't make my rent due to being off of work for an unknown amount of time. I'm still required to do almost all the same things as Maximus, such as required drug testing weekly, required meetings, monitoring at work, psych, evals, etc. Thank you.
Thank you for your comment. Jessica would like to make a comment. 1 second, please. I'm gonna try Jessica on the computer.
Thank you. Can you hear me?
Yes, ma'am, go ahead.
Thank you. All right. Well, thank you so much for allowing me the chance to make a public comment on this forum. I've wanted to shed light on this issue for a while, but I've always felt like I needed to speak about the patient care mandate first, so I haven't been able to share about this topic yet. But I want to speak regarding the illusion of choice when it comes to the SUD support programs. Although Maximus doesn't outright demand that we choose AA or NA, they certainly have other ways of influencing our supposed decision regarding which group we attend. I want to share my story. I have deep rooted religious trauma. My case manager, who is no longer with Maximus, I don't want anyone to get in trouble, but initially, she knew this. While Maximus didn't, or she, I should say, didn't directly demand that I participate in AA, my case manager at the time certainly relentlessly and repeatedly encouraged it. She expressed her disappointment each and every time we spoke that I wasn't choosing AA. I told her that I didn't have a higher power and that I cannot separate the idea of a higher power from God. And she repeatedly tried to encourage me to accept a sunflower or nature as a higher power in my life. I continued to tell her that I didn't believe a blade of grass has power in my life, but she continued to strongly and repeatedly encourage AA and a higher power. This case manager actually told me, "We can't force you to join AA, but," with a very meaningful pause. I struggled against this for months on end. I attended meetings in Smart Recovery, Dharma Recovery, Life Ring, Women for Sobriety, and even AA, NA, and Celebrate Recovery. I gave it a chance. My absolute favorite recovery group was Dharma Recovery. I felt a kinship with the participants and enjoyed that the doctrine is focused on your own actions, thoughts, and relationships with others. When it came to finding the mandated sponsor for these groups, it was difficult. Sponsors are not an integrated part of any of the support groups I felt comfortable in. I was able to find people willing to sponsor me, but none of them met the requirements of 5 year sobriety, same gender, and local. So after much fighting, I gave up and I joined AA. I found the easiest way to digest the AA doctrine was online. Unfortunately, I'm now required to attend in-person meetings and encouraged one a week, but encouraged to attend as much as possible because they believe that's what's best for me. AA meetings, especially in person, are incredibly triggering for me, even to this day. I feel my heart race, my hands shake, and sometimes I feel a tightness in my chest or silently cry for no reason. And I'm not a mentally weak person. It's just an uncontrollable response to the church pews, the frequent praising of God, the prayers, etc. But now I have to pretend I'm a big AA believer because until I bent to their will and did what they wanted, I couldn't move forward. I was denied everything until I finally got a sponsor and joined AA. I know I'm not the only person who is staying silent and just doing what Maximus wants. I think that the requirements for a sponsor should be lifted if someone wants to join a different support group. The words 12 steps should be replaced with support group on our monthly check-in forms, during our check-in calls, on the FS Solution website, the travel forms.
Thank you for your comment. Jessica on the cell phone would like to make a comment, I hope. 1 second, please. Jessica on the cell phone, there you go.
Oh, yeah. I didn't request to make another comment.
Oh,
Thank
okay,
you.
no problem. There's 2 Jessicas and I just wanted to make sure I got the right Jessica.
Thank you. I appreciate that.
Thank you. Okay, anonymous on the cell phone.
I'm a recent or new participant in the intervention program. I received an email that was referring me to the program. It didn't outright state that I joined, as it's voluntary, but my hope in joining this program was, to get help for mental health that can affect your practice as a nurse. But now I'm not even sure that I joined the right program, though I do want to improve that aspect of my professional practice and even personally. Um, I I don't know if I would like to think that this is an alternative to discipline program and we don't want harm to our patients. What does harm actually mean? Because I feel that once an investigation goes through my complaint, which I just found out about the complaint process and the investigation. Like, does this mean that once a verdict is reached that I'm automatically going to be put on probation? I know that we all have to answer for our actions, but I'm afraid now that I'm in intervention, I'm in a 3 to 5 year contract that's very costly, and I want it to help me, but I don't know if I joined the right program, and I want somebody to answer that question for me. And what is, defined by patient harm? Thank you.
Thank you for your comment. Maria would like to make a comment. 1 second, please.
Yes, hi. So I'm wondering if there should be a pathway for participants to be able to start an appeal process, just like any business, any company does, instead of having us wait until their next IEC meeting. I had to wait 3 months, but I heard someone else has to wait 6 months. But in the meantime, we're continuing to spend money on drug testing. This month already, I've already spent $1,400, including the psych eval that they requested. And even though, after being sober all these years, 4.5, hasn't been a pathway for appeal, because all they say is there's really nothing on paper. And I think that would be something that would be very helpful, especially if there is good reasoning for a participant to want to open an appeal of why a decision was made. And if so, they need to tell us what the reason is, instead of just leaving us in limbo like I am at this point. So I don't know if that would be something that would be considered, but again, an appeal process, any business has an appeal process, and the recovery program should have one as well for us. And that's all I need to say. Thank you.
Thank you for your comment. David would like to make a comment. 1 second, please. David, go ahead.
Yeah, good afternoon. Can you hear me?
Yes, sir.
Great. First, I just want to say, I'm very appreciative of this program, and even more so the fact that everyone is addressing the public comments and concerns. It's a definite positive in the right direction. Very grateful for that. My comment is regarding going out of the U.S. and in relation to testing. I am a participant, and I was selected for hair and blood, say just for numbers and calendar purposes to give an idea, say in January. I then went on a vacation out of the country in February. When I got back from that vacation, I was instructed that I had to do a hair, blood, and urine on top of the already implemented monthly testing. So I incurred a bill of well over $1,000 just for those 3 tests, simply because I went on vacation. And I would just ask that the committee kind of look at that in the essence that I had already given blood and hair just before I went on vacation. And then there's like this blanket policy that if you leave for any amount of time, greater than 24 hours out of the country, you're immediately going to be required to supply that again. And I would just ask if you could please review that as a blanket policy, and if it's really needed. That's it. Again, grateful for the program. Thank you.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. Do we have any public requests for comments there in DCA HQ?
No, there are no requests for comments here in HQ.
Thank you. Would you like me to close this window?
Yes, thank you. At this time, this is the end of our second day of the Board of Registered Nursing Board meeting. It's not agenda.
I'm sorry.
At this time, we will adjourn. Thank you for joining us and have a good evening.